الخلق الله أجمعين. يسعدني ويشرفني اليوم إن شاء الله يكون آخر ويبينار في سنة 2023 يبقى مع هؤلاء العمالقة، وأنا أضيف عليهم الحقيقة يعني. والحقيقة يعني إن هم مبادرين عظماء في عطائهم، يعني لا يبخلوا بأي جهد ولا بأي طاقة في تعليم الناس ونشر العلم. والحقيقة هم بذلوا جهد خرافي وبذلوا وقت طويل جدا جدا عشان يطلعوا يوم أنا بعتبره ميني كونفرنس، يعني بالأداء، بمستوى الأداء، بمستوى المعلومات اللي هتتقال، بمستوى البراكتيكال اكسبيرينسز اللي هتبقى موجودة النهاردة. ده ميني كونفرنس على الهيب جوينت. فيعني إن شاء الله ربنا يجعله في ميزان حسناتهم ويتقبل منهم. وشكرا جزيلا.
Dr. Safa, sorry, there is
نبيل
a many
كسباني.
people speaking English. Just make a message. Just please speak English.
حاضر، أنا هاخد
Because don't understand anything.
بس okay. It is my great honor and pleasure to celebrate the presence of Professor Dr. Nabil Kasabani, Dr. Yasser Tobl, Dr. Sahar Kamal, Dr. Wissam Dir Sultan, Dr. Yasser Al-Tayyib, at the end of our scientific e-learning program, continuous e-learning program in 2023. This is the end of the year. It's really majestic and magic, marvelous end to have all these legion of pain and regional anesthesia. I'm so happy, I'm so proud to be among them. I will leave, of course, because this webinar will be moderated by all the faculty and we will present it by all the faculty. I wish you happy time. I wish you joyful time and very, very elegant Congress. Thank you for you all. دكتور وسام تفضل قدم. اتفضل.
السلام عليكم. I think Dr. Nabil will introduce the topic today. Dr. Nabil.
Assalamu alaikum, Dr. Safa. Thank you very much for the kind invitation, and it is my pleasure to join you guys today. And it's my pleasure and privilege to be joined by my co-panelist. I think none of them need introduction to this group, okay? But nevertheless, I'm joined today by Dr. Safa. Dr. Safa is the president of the society, and Dr. Yasser Al-Tayyib from Qatar. Dr. Yasser Tobli also works in Qatar. Dr. Wissam Din Sultan, I know Wissam since a long while ago now, and he works in Manufia University, and Dr. Sahar Kamal from Ain Shams. So today our topic is something that is very common, whether you are working in Egypt, whether you're working in the Gulf area, whether you work in the United States. This is something that you're going to be faced with and you have to deal with almost on a daily basis. And the topic is about hip fracture. And as I mentioned earlier, it's my pleasure to be hosted by this wonderful group of co-panelists. So we thought one of the good ways to give you very rounded picture of the practice and the perioperative management of hip fracture is to just be guided by a case vignette in the beginning. So this is something that you've seen in your theater, almost every day. So they called you from the emergency department that you have a 90-year-old woman who suffered mechanical fall at home. She tripped over her cat. Her past medical history is mild dementia. She's diabetic. She had an MI 20 years ago, and she has hypothyroidism. She lives in assisted living home, and she walks with a cane. And she presented to the emergency department on Tuesday morning at 2 o'clock in the morning. Just when the emergency physician doctor was asking her, she denies chest pain. She denies shortness of breath. She can walk unlimited distance with her cane, but she's just limited by her arthritis. when she fell, she denies loss of consciousness, and she does remember the whole event. She doesn't have any other symptoms really. On physical exam, she's alert oriented time 3. Just the orthopedic resident, like when they were examining her, they found like one limb shorter than the other, and it was just painful and tender to touch. And she's, other than that, she's neurologically intact and her distal pulses are all intact. Cardiovascular examination is unremarkable, so as the chest is clear to auscultation. We thin her to chest x-ray, and this is the x-ray that we get, and you see here that you have the hip fracture as we pointed by the mouse pointer. So the ED resident called the orthopedic junior resident, and hey, we have this 90 years old. The orthopedic resident, great, thanks. Just let's get like everything under the sun, everything that you can think of. CBC, PMB, coax, chest x-ray, EKG, and just put a medicine consult for OR clearance. It's almost like a reflex without really just looking at her or just thinking about like what's going on. So her labs came back. It's pretty much unremarkable except for some troponin that was at a value of 0.235. And on the EKG, it looks like it's unchanged from 2 or 3 months ago, and she had some evidence of old inferior MI. So just to show you the timeline, so the staff consult was around like 9 a.m. Tuesday. This is the medicine staff consult that was requested. So the patient was not cleared because she has troponin, and they decided to follow a serial troponin like on Tuesday. And Wednesday morning, they decided that this young lady, she needs an echo, and the echo was done on Wednesday. And as you see, the ejection fraction was 50%, no one motion abnormalities, and otherwise normal. So she was cleared for the OR around Wednesday at 5 p.m. Mind you that she was admitted at Tuesday, 2 o'clock in the morning. All right, so we're going to do her like Thursday morning, but lo and behold, there are 2 cases, 2 emergency cases that came through the ER, and that was added to the orthopedic list. So now she got pushed back to the back of the orthopedic list. And at 5 o'clock in the morning, like you were running 2 rooms, but now they got shut down to 2 rooms. So they decided to do her as a first case in the morning. So that case was done at Friday in the morning and underwent uncomplicated hemiarthroplasty, and she was discharged to rehab 4 days later from the hospital. So the discussion is going to revolve around what is the preoperative workup and the preoperative assessment for patient with hip fracture. And the points of discussion that we're going to allude to is whether this is a clearance versus risk stratification, what is the minimum acceptable workup for these patients, whether you do lab work, echo, any cardiac investigations, role of the preoperative troponin, and really minimal delays versus maximal optimization of the various cardiac risk factors. And with that, I'm going to invite Dr. Wissam Sultan to just join us and share his screen. And I think he's going to go over the next 15-20 minutes for the optimal workup for these patients. Wissam,
Yes.
I'm going to stop sharing, and it's all yours.
Okay. Thank you, Dr. Nabil. It's a very honor to be among these faculties. Thank you for inviting Dr. Safa. Thank you, Dr. Nabil. Thank you for the Dr. Yasser, Dr. Sahar. Just want to share. Is it okay or not yet?
We can see it, Wissam. If you want to push the slide icon at the bottom also to just show the slideshow, that would be nice.
Okay, I'm just looking for it. Dr. Yasser, it is the same problem with you before. I don't know how can do it.
Just hover over
Just push the bar down to left, you found the icon.
Okay. Okay.
You can see it, yeah.
دكتور وسام في رساله
Yes.
طالعه بس اللي هي الخط الاصفر اللي هي
Done. Done now, it's okay?
It's okay, yeah, go on.
Okay. So tonight I'm going to talk about the preoperative assessment of hip fracture in elderly patients. As we know, the hip fracture is the most common fracture in elderly patients. It accounts almost 300,000 per year fracture. This is a statistical data from USA. We have many types of hip fracture. It might be intracapsular or extracapsular, displaced or non-displaced, subtrochanteric, intertrochanteric. Why we are talking about the elderly? Because elderly accounts high number of population. As we can see here, the blue columns for the number of population of elderly above 65 years. And the red line, it's for the percentage of the elderly patient among the whole population. So, for example, in 2020, we can see that to do it outside. In 2020, we can see that the population might be above 55 millions, with a percentage of 15 from the population. At 2050, it will reach above 80 millions and accounts almost 23% from the population. This is because of the improvement and advances in medical facilities and health service care. It's not. So another graphs we can see here the morbidity incidence of morbidity. The incidence of morbidity is exponentially increasing with aging because of the aging process. And with incidence of fractures, we can see that the highest incidence of morbidity increasing more with the hip fracture. What are the predisposing factors for that, for the elderly? Because the number one, osteoporotic changes happened with the elderly group, which lead to lower limb dysfunction. Visual impairment might be a cause. Parkinson's disease, previous fracture and stroke, which leads to unstable gaiting, might favor to fall down. The female gender because of the hormonal changes. Dementia, alcohol consumption, and psychotropic medications, especially in the first few days of medications. Actually, this fractures has an impact over the patient himself and the community. Regarding the individual impact, it's the patients with reduced mobility, which leads to bed sores, incidence of pneumonia, thromboembolic manifestations, loss of muscle mass, and ended up by death. But the community impact, actually, it hosts the medical services, and it has a great economic strain on healthcare system, and the expenses might exceed $6 billion a year. The whole incidence of hip fracture during in elderly group, it was 28% worldwide, but with the advancement and in the medical service, it reduced to 21 in USA and the least 18 in Asia and 27 the maximum in South America. Actually, we don't have any data from Africa. So what about the mortality rate post-surgery? Actually, irrespective to time to intervene early or delay, it accounts 9% in 30 days. In the first month, the mortality is 9%. It doubled within the first 3 months, up to 18, and it became 30% in the first year post-operatively. So this is regarding the surgery. Do we have a conservative or non-surgical management? Yes, we have. But when we can do it, what is the indication for conservative management? Actually, we can do it for the terminally ill patients. Patients cannot walk, like patients, paraplegic patients, patients with severe dementia, and serious comorbidity like end-stage cancer disease or advanced hepatic diseases. What is the sequelae of that? Actually, it will lead to significant pain, shortened legs, immobility, subsequent complication with immobility, and then at end will end by death. So, timing for doing the operation or to intervention. Is it urgent or emergent procedures? Actually, hopefully, we want it to be emergency, but we cannot do it like emergency cases because this elderly group has a lot of comorbidities, sometimes serious comorbidities. So the medical condition should be optimized before the operation. So the best results is within the first 24 hours. And we can stay for 48 hours if the patient need to optimize the medical conditions. This is in patients with comorbidities. In healthy patients without any comorbidities, we can do it within 4 days. So to summarize the preoperative assessment, we will take a full history from the patient, history of the previous surgery, history of the medications, a history of any medical illness before. And while we are taking the history, we can take blood samples for routine laboratory investigations and cross-matching of blood if needed, and doing a physical examination to the patient, imaging study, and medical optimization, and then go to the OR within the first 24 to maximum 48 hours from admission. So particularly, we can talk about the fall. We have to evaluate the cause of the fall. Is it slipping, just slipping or tripping, or it is preceded by loss of consciousness and dizziness? So we have to know to exclude the cardiac and the neurological syncopal episodes. Respiratory, we know that we have a lot of changes regarding the lung of the elderly patients. So we have to identify the patient with respiratory problems, either restrictive lung diseases, obstructive lung diseases, acute or exacerbation of bronchospasm. So hypoxemia and bronchospasm should be corrected immediately by applying oxygen by any means or doing intense bronchodilator therapy and nebulization to optimize the situation. And in severe pulmonary affection, we have a choice of regional anesthesia. Cardiovascular system, which is very important issues for this kind of age group. So if we have established the cardiac history, like this patient, stable cardiac conditions, no signs and symptoms of decompensation with average functional capacity. So if yes, proceed without any further investigation. If no, just do cardiology consultation with further investigations like troponin, ECG, transthoracic echo, stress tests, mainly pharmacological, whatever. And then optimize the case as soon as possible, maximally within 48 hours, and proceed for the procedures. We have a question here. Should we have a cardiac consultation for all the patient? The answer is no. Actually, we can do it for high-risk patients, unstable cardiac conditions, and if the cardiologist will be involved in the post-operative plan. Question number 2, should we have an echo for all the patients? Actually, no. But when we can do it, if we have signs and symptoms of acute heart failure, signs and symptoms of severe pulmonary hypertension, signs and symptoms of severe aortic stenosis. And sometimes we have patients with arrhythmias, presented with arrhythmias, and arrhythmias might be the cause of fall down. So arrhythmias will be presented either with tachyarrhythmia or bradyarrhythmia. Tachyarrhythmia in the form of supraventricular tachycardia, atrial fibrillation, or atrial flutter. If we have this and the patient is stable, just control the ventricular rate. If the patient is unstable, we can do cardioversion, as you know. And bradyarrhythmia in the form of MOBS type 2 heart block or complete heart block. If we have such cases, we have to insert temporary pacemaker, intravenous temporary pacemaker. Then after that, proceed for the operation. Most of the patients also came to the ER with dehydration and signs of acute kidney injury. If we have acute kidney injury, this is because of the dehydration, use of ACE inhibitor and angiotensin receptor blockers, presence or existing of coronary artery diseases, and blood transfusion. And most probably, the lab works will show low albumin in such cases. So if the patient has acute kidney injury, it will lead to long stay in the hospital and delay of surgery, and then will have high mortality and morbidity rate. So if we have AKI, we have to early hydrate the patient with isotonic fluids, stop the ACE inhibitor and the ARBs, and adjust antihypertensive medications, and doing a serial assessment of the kidney function, mainly post-operative. And in case of we don't have evidence of dehydration or AKI, and there is signs and symptoms of peripheral fluid overload and decompensated heart failure, at that time, please do not give ample fluids intravenous. Be restrictive in transfusing the IV fluids. Regarding the diabetic patients, we have to check the blood glucose level, which should be monitored carefully. We have to avoid the hypoglycemia associated with high rate of death. Insulin is given once the glucose level more than 180 milligram per deciliters, and the basal insulin dose is 0.1 to 0.15 unit per kg per day. Anemia, we might have patients with anemia. It's commonly happened due to the bleeding at the fracture site. It ranges from 24% to 44% preoperatively, and increasing post-operatively up to 51 to 87%. So cross-matching of blood or RBCs back to RBCs is considered such patients. And there is a focus trial done to check the threshold for blood transfusion. It's a multicentric trial, functional outcomes in cardiovascular patients undergoing surgical hip fracture repair. It was a randomized controlled trial to address the transfusion goal. It was done on patients over 50 years old with a history of ischemic heart disease. And they can conclude at the end, a post-operative hemoglobin transfusion threshold of 8 grams per deciliter in the absence of symptomatic anemia was considered acceptable in elderly patients with or at risk of ischemic heart diseases. So regarding a big issue in such patients, most of them are on either antiplatelet medications or anticoagulants drugs. So this research done, or this review article done by the Archives of Bone and Joint Surgery in 2022, the perioperative management of antiplatelet and anticoagulant drugs in hip fractures, and they commented that do the surgery as early as possible. I will try to just summarize this review articles. We have 3 types of patients, either patient on antiplatelet or dual antiplatelet, patient with vitamin K antagonists like warfarin, patients with new oral anticoagulants. So in the case of antiplatelet, tranexamic acid is considered in such cases, and platelet transfusion if needed. This is not the first line of management in such cases. So platelet transfusion when needed, just to prepare it, but do not transfuse except if we need it. And they conclude that in dual antiplatelet therapy, the risk of mortality and the morbidity related to delayed surgery would be greater than the risk of bleeding. In the second group, patient with warfarin or vitamin K antagonists, we can manage it with vitamin K intravenously or oral vitamin K. Actually, intravenous will start to produce the effect within hours, but the oral will take days. Fresh frozen plasma and prothrombin complex concentrates, we might use it just in need also. And the bridging therapy by like enoxaparin or whatever, we can consider it in certain cases of high-risk patients, like patients with prosthetic valve replacement or patients with atrial fibrillations. And they said that in high-risk patients on vitamin K antagonists, a multidisciplinary approach with anesthesiologists, cardiologists, and hematologists should be employed. Regarding the last group with new oral anticoagulants, we can use fresh frozen plasma or prothrombin complex concentrates. Charcoal injection, it helps if the patient is receiving the medication earlier, and hemodialysis in certain conditions. And they conclude that the new oral anticoagulants were not associated with an increased perioperative blood loss or mortality compared to the control group. Another patient: is hip fracture surgery safe for patients on antiplatelet drugs? And is it necessary to delay surgery? This is a systematic review. It was done over 24 studies, including almost 5,500 participants. They are divided into two groups. The group with early surgery without stopping the antiplatelet, and delayed group after delayed surgery after stop the antiplatelet. They found that the blood loss or hemoglobin level are decrease more in the group with the antiplatelet, and the transfusion rate also is higher in this group, but length of stay in hospital and the mortality rate are decreased. And the delay with delayed surgery, length of stay and the mortality are increased. So they said, conclude that it is unnecessary to delay surgery to restore platelet function when patients with hip fractures receive antiplatelet therapy. So this is the time to risk stratifying the patient. We have an urgent procedure with intermediate risk surgery and elderly patients with comorbidity. So we have major cardiac events ranging from 1% to 5%. Actually, this percentage increasing with active or uncontrolled cardiac conditions. So in such patients, we have to do revised cardiac risk index and do serial troponin to see if there is any evidence of myocardial injury or myocardial infarction. And for our patient, I think this is a straightforward case. No active cardiac conditions, lab works are fine. There is no another things can be done for the patient. So I think we can pass with the patient to the OR within few hours from the admission of the patient. And I think this will be helpful for the patient. Thank you.
Well, thank you, Sam. So that was very informative. I'm going to ask everybody to hold on to your questions until the very end. And at the end, we're going to have a very robust discussion about everything that we're going to talk about, like in this symposium. All right, great. So we're still with our patients, if you remember, and our patient is now ready to proceed, like according to Sam. So guess who was staffing with the OR that day? It was Dr. Yasser. And Dr. Yasser essentially just he goes and say hi to the patient, and then her son just is telling Dr. Yasser that actually a couple of years ago that this patient underwent inguinal hernia repair, and she got general anesthesia for that. And he said my mom was very difficult to come out. And for the next couple of days, after surgery, she was very confused. And I'm really concerned about the effect of anesthesia. And he was asking Dr. Yasser to discuss with him if there is any other option that he can offer for anesthesia for that patient. And then Dr. Yasser is going to go extensively into just explaining to him and to us and to you guys and everyone, like, you know, what are the different options for anesthesia and what's the pros and cons of each one of them. Dr. Yasser, this is all you.
Thank you, Dr. Nabil. Thanks for that attendee. I know that most of people leaving their work. I will try to make as long as possible to cover the subject, and as short as possible not to get bored or to fall asleep. So I don't have any conflict of interest related to the presentation, and my objective will be introduction about the disease for fracture, the current controversy about the different methods of anesthesia. We can implement a strategy to treat complication, and we're looking all the time for evidence base about our practice to make the best practice. And at the end, I will just give you a choice about our case discussion and conclusion. So whatever use in general anesthesia, sorry, or neuroaxial anesthesia, the debate will stay forever because nothing is ideal and everything have a role in our practice. But the most important for us is the safety. Safety is paramount for the patient. And our role now, not concerned to be an intraoperative. Now, the preoperative management for anesthesia, not like before, 30 years ago or more. Now, we prepare our patient, we make an anesthesia, and we care patient until he leaves home. So the most important thing to recover the patient in a smooth way, to make him happy, and to discharge to his home or department in the best state. We'll speak now about one of the topic about the anesthesia. I just return back to the history when make anesthesia like this, and also my grandpa in 1942, they make above knee amputation without anesthesia. I can imagine, and he died after 6 years. You can imagine about this type of anesthesia. And now the anesthesia become very luxurious. You know, even this gentleman asking about cricket, because this Ganesh Chaudhary is my friend from India, but like this sport, and his comfort in his bed, and even he update his operation in Facebook during surgery. Starting, what is the option for anesthesia? So whatever it is, neuroaxial or spinal, I just will give you a brief about you know, hip fracture. It is one of the major and interesting concern in anesthesia. Today I was on call. We have 5 cases fracture, and 4 of them is adult. So it's all the lady, all the people like this lady is the same. And you can know this another statistic from Osam, 77.210 femoral fracture happen in UK and Ireland. And hip fracture is still also one of the most common cause of death and injury and complication. As we said, it may be the statistics here is less than 6 to 13% get a mortality rate in 30 days. And we need a clinical guideline all the time for standardize the work, not different from 1-to-1. And still, also, the mortality, 1-year mortality is high, as I said. Early surgery, imperfectibly for mortality. It can decrease the incidence of mortality, morbidity. And what we said here is that regional anesthesia not improve mortality or ambulation after 60 days or delirium for regional anesthesia. General anesthesia, it can increase in hospital mortality, but not 30 days or the 60 days for mortality. So something coming against the logic. We think that spinal is very safe, general have a problem, but the outcome, it may be more or less equal in some factors and some complication, different some complication. So the problem with this topic, because most of the study looking for primary or secondary outcome in a different prospect. So some study looking for respiratory infection and failure after surgery, some looking for delirium, some looking for hospital mortality or mortality after 30 days, 60 days, or 1 year. And some studies looking for bleeding and cerebrovascular complication, even post-operative complication like cerebrovascular complication or even neural complication, kidney complication. To start with, that anesthesia itself carry inherited risk. Usually anesthesia producing a risk, even for SO1, you have an incidence of complication, even a remote possibility, but it can happen. The increase on the comorbidities increase the risk of anesthesia. You know, if you speak about age alone, you know, this 95 years old and you don't have any disease, still this patient is concerned and high risk because a reserve of the organ function, because you all the time degeneration of the liver, kidney, all the organs of the body, so it's not working like a normal. So I want to ask a question: does the mechanism or what's called the technique of anesthesia produce different outcome or not? We can go through this to see the type of anesthesia. If we're looking for the option of anesthesia for such cases, it can be general anesthesia, neuroaxial, like spinal epidural, or nerve block with sedation, like a local anesthesia infiltration or nerve block with sedation. And it may be a combination of this technique. So whatever you do, spinal or general anesthesia or nerve block with sedation or without sedation, still there is an advantage of every technique and disadvantage. If we look for advantage of regional anesthesia, we know most of all that because reduce blood loss, reducing the need of blood transfusion most of the time, decrease bleeding at operative site, and even improve cement bonding because this decrease bleeding doing that. Shorter surgical time, but really it is a limited for the time, and sometimes you have a failure for regional anesthesia. And reduce the incidence for most of the study for DVT and pulmonary embolism. Avoid the effect of general anesthesia on pulmonary function like atelectasis, pneumonia, postoperative respiratory complication. Provide good early postoperative analgesia because the patient is awake and have an analgesia, still analgesia, and also lowest cost, except especially in the low socioeconomic standard. But the problem, it needs some skills. So in our training, you can take about 100 cases of general anesthesia and still you don't do any regional anesthesia. But spinal anesthesia not an one fit all. Sometimes you have a problem with regional anesthesia, spinal or epidural, like extreme age, patient, if you have a ligamentum villefum calcified, deformity of the back, presence of hypovolemia, heart disease, and other complication or other contraindication for regional anesthesia, as you know. The advantage of general anesthesia, it is usually advantage for the patient, better for patients who are unable to lie flat because of pain, and safer in patient like an fixed cardiac output, mitral stenosis, some patient with what's called aortic stenosis because of hypertension. And sometimes most of the patient prefer it, even sometimes risky. And you don't need usually urinary catheter like epidural spinal. Sometimes you need unlimited time and no failure. You can make it forever, 24 hours. I make a case 36 hours for vascular when I was resident, and you can do by any other methods. Also, all the time, patient like to be unconscious. Disadvantage, you need a strong narcotic postoperatively make the patient to feel unwell and have a complication. And also, it is a very bad choice in cardiac and some chest problem. And, don't forget the most complication of anesthesia, to put the tube, to remove the tube. So have a complication of intubation, especially in old ages. And many times you can get complication of many drugs used, so use a pharmacy. Also, technical and non-technical problem can make it difficult. So all the time, just looking for evidence to make the best practice. According to our recent study, marriage is the main reason behind divorce. I think it's taken a class for evidence. Why looking for evidence to use the best practice? But unfortunately, when you make an analysis for the data, you can find variability of the result because the data different from, that when you make a study, it need a good construction for the study, looking for the primary and secondary outcome, and different from area to area. But most of the studies showing that as evidence, no great difference. It may be minimal difference between regional and general anesthesia. Even regional anesthesia in some cases, lower rate of thromboembolism and bleeding. And also because this practice variation, it is very difficult to generate an evidence, because you must be looking for the impact of surgery, quality, also geriatric care and rehabilitation, also not found everywhere. Anesthesia is the most important about anesthesia is the monitoring and controlling the physiological parameter to make it as normal. So monitoring temperature, blood pressure as normal, adequate volume, antibiotic prophylaxis, and positioning. How to conduct anesthesia for this patient? You must remember that you have a lower reserve. So titrate your drug in an anesthetic depth. Don't give it liberally like an adult. Also, you can use a nerve block to minimize the anesthesia and opioids. And some people said if you make it what's called mechanical ventilation is more worse for the patient. When, for example, you put an laryngeal mask airway was blocked, it can make a atelectasis, barotrauma, and hypotension, fuse beep. And also remember that this patient in trauma have a severe pain and they take an opioid to decrease the pain, so delayed gastric emitting. And again, if the patient sleep on side and he cover, sometimes he have a difficulty when you needed to put an urgent emergency tube for this patient. As I told you that age is not a risk factor, but delayed what's called a reserve for the patient. Frailty and comorbidity is very common in old patient, but I think this patient was dancing, he removed everything. And proceeding to surgery may appear as high risk most of the time, but we must remember that non-surgery is more risky than to do the surgery. As here, this is a statistic as risk of non-operating higher, because it is it can higher on week because of mechanism embolization. You can know from the statistic here, 48, that's around 50%. No surgery, die in hospital, compared to 6.6 if the patient make a surgery. So because the surgical repair can control the pain and help in immobilization. The problem with pain and immobilization. So Sarier shows that 90.4% increase in surgery days mortality when surgery take more than 24 hours. Delaying surgery 1 day increases the risk of delirium twofold, increasing risk of complication different from complication to complication. And even randomized control study when accelerated what's called to make the operation within 6 hours, and comparing to make it 24 hours, there is no decrease in 90-day mortality, but it may be an increase the level of mobilization or the decrease of DVT and other complications. So the most important in anesthesia to avoid or to make the what's called the physiological parameter more or less the same. So to avoid hypotension, because it's associated with mortality and morbidity, and don't make it the mean below 80 for 10 minutes, make a catastrophe, because all the organs suffer from this hypotension. And most of the time, suggesting small dose of bupivacaine, especially if you work with a good surgeon, professional, working fast, and also all the time you must looking for monitoring for the hypotension and to treating proactively before to done. Again, post-cement implantation syndrome, one of the causes, which is maybe common when you put a cement to make an hypotension. And to avoid hypotension, you're also looking for the risk factor, which include male sex, use of diuretic, significant cardiopulmonary disease, increasing age, and you know that British Orthopedic Association, British Geriatric Society, and the Association of Anesthesia has issued guidance to reduce the risk of hypotension in the guideline. I will just speak about it later. And also avoid cognitive complication like delirium. How can you avoid, you know, the incidence between the two, general and regional more or less the same, but have a very long-lasting effect and make psychological impact for the patient. And sometimes he never return back to himself. So, and to avoid the drugs like opioids, cyclazine, atropine, to do regional anesthesia, and to avoid most of the time sedation, to avoid drug like antihistaminic, antipsychotic, anticholinergic. Anemia, I think my colleague Wissam speak about it, but you know, there is a debate which is the normal figure, because Wissam make it very easy, like an algorithm if you don't do that. But in reality, we don't found that. So it is just based on the judgment, on the comorbidity, on the patient, on the acuity for the anemia. You know, some people can live for 8 for a long time, has no problem, it's chronic, but they can't live for 10 if it happened very fast. But just remember 8 and 10. In some patient with high comorbidity, if he lose one drop, you can give him just the same drop, but some patient can't tolerate. So a strategy to decrease the blood loss, expediting surgery, minimize operating time is very important, use of tranexamic acid, and as Dr. Wissam said. But again, as he said about cardiovascular complication and occult cardiac problems, he found that 25% of patients have an audible murmur on examination for geriatric. And sometimes they lose all the symptoms like chest pain, reduced exercise, or syncope. Never happened for some patient and still have a very big murmur. Preoperative echocardiogram can influence anesthetic management for those people. Surgery should not be delayed waiting for echocardiography for minimum, because you know that you must balance the delay against that to discover something. I have a patient today the same like this, still waiting for 2 days. And the cardiovascular stability by IV fluid and vasoactive drugs. Antiplatelet, I will not speak about it, but I'm telling you what I found, that patient with INR, above 1.5 should receive the vitamin K, and bridging can be used. Single antiplatelet therapy not a contraindication for anesthesia, and must all the time balancing the life of the patient, the outcome of the patient against spinal hematoma, which is very rare. And there is a lot of controversy about this topic, even despite advancing evidence and answer questions still remain. Practice care of patient may not allow for generic guidelines, because the guidelines is just a guidelines. It can't be practiced for everyone, and it's different from area to area. And also the dilemma can be approached by tailored anesthesia technique at a time. And you deal with the physiology for this always. Conduct of anesthesia, as I told you, to go according to Association of Anesthesia. Some people said below 10 milligram, but different from area, and no one just follow, because sometimes the patient need more if have, but the most important to avoid hypotension, delirium, and urinary retention. Prolonged surgery, you can make use of infiltration or to give systemic analgesic, or conversion to sedation or general anesthesia. Sedative drugs, we found that in the UK and Europe, that about 74% of people with spinal anesthesia get some sedation. And I think because of that, there is some bias about the spinal anesthesia, because most of the studies don't show all the time that he gets a sedation or not, because for a long time, the patient can't tolerate the position. And also position for spinal anesthesia. Post-operative recovery is very important for this patient. He need an early mobilization, and the patient he need a high dependent unit or not, or he need an what's called as has comorbidity, like an other non-cardiac case or cardiac case for non-cardiac surgery. And there is a consultation to work like one team, and you must have a pathway for this, for rehabilitation. And also he must have a team from also geriatric, occupational physiotherapy, and psychotherapy, all these people working for him. That as a consent, the problem with consenting, this patient mostly have dementia like our patient, and they have cognitive impairment. Also, most of all the patients don't like to engage in this discussion and the risk for his case. And usually you need involvement the family about the case, and consenting should over a choice also all the time. The patient now it changes from a person who suffered to a customer. So a customer must be happy about his management, and discuss with him general anesthesia, spinal anesthesia, nerve block, and advantage of everything. Speaking about spinal anesthesia, as a preparation, it need a preload to examine the patient for any contraindication, for history, and to examine him for back or deformity or anything. But most of the time, some people using another drug to increase the time of anesthesia and analgesia, but take care, because this patient can be very fragile. If you give him a fentanyl or morphine, he can get a severe spiral depression or spiral depression. So now I'll coming to the studies, some evidence. This study, and I think I found one study from Dr. Nabil himself, and I bring one study from our department. General versus general anesthesia for hip fracture surgery, meta-analysis and randomized control studies. The conclusion: no consensus regarding the safest anesthesia for any patient. Operation under JA had a reduction in operating room time. And another study showing that spinal have reduction in operating room time. Low incidence of myocardial infarction and confusion and hypoxia in this group. Lower incidence of cardiovascular accident and post-operative hypotension in general anesthesia group. Marginal advantage for regional anesthesia compared to general anesthesia in mortality and DVT. Collectively, if you found this, that whatever you muster, you can use it in the best way for the patient. And most of I tell you, one of the common things, 74% to use an sedation, reduce the sedation, but using the sedation increase the delirium, as we know. And you can use a face mask, a laryngeal mask, even TCI for propofol, and some people use an Berizedex, dexmedetomidine. And you know that the most important, we have many cases to do under nerve block with sedation, and epidural can be considered some complex surgery, but the problem have many problems I will show later. Not usually required for uncomplicated surgery. Insertion of uric acid is most common. And also sedation, I will not go about sedation, but it must be tailored upon the patient for his requirement and not to give in routine. Post-operative, very important positioning for the patient, analgesia, fluid balance, check hemoglobin, oxygen therapy, and to look for complication like blood loss after operation. Many patients get a very big amount of drain. Today get about 500 in half an hour, and it was a bleeding inside. Similar amount to be lost in the tissue post-operative. You look for venous thromboembolism and how to make a prophylactic and how to treat it. Just it's called balanced against thrombosis for this patient, and also semen reaction, because this reaction can mostly happen during semen interoperative, but in more rare cases it can happen post-operatively, and it appears by hypoxia, hypotension, cardiovascular collapse, and cardiac arrest. Usually this is because when just the semen extend on the lumen for the bone, it can make a fast embolization during increased intra-abdominal pressure, and this is a manifestation which happen: hypoxia, sudden loss of arterial pressure, pulmonary hypertension, arrhythmia, loss of consciousness, and cardiac arrest. And when cardiac arrest happen, you know, this is the only time when the surgeon, after prescribing, he sit down like this and keep calm and believe anesthesia all the time. So prevention and the treatment: increase in spinal oxygen concentration prior to cementing as a proactive, measure blood pressure frequently, ensure adequate blood volume prior to cementing, stop nitrous if used, alpha agonists like methoxamine to treat hypertension, suction of the bone cavity to evacuate air and fat during insertion. We must speak a little about now the era about enhanced recovery, because this is more better for the patient, more better for the society, more better third party for paying. So in most hospitals, starting preparation the patient, he went just reaching the hospital, and usually done by regional anesthesia, nerve block with wound infiltration. And but remember, the patient preference is important. And I will tell him nothing will happen without your opinion. You know, this paper, when it come, it make it was a lot of bias about this paper. The New England Journal of what the paper said: spinal anesthesia or general anesthesia for hip surgery in older adults. You know, they said that this or a new ability to walk 60 days not different in USA. Spinal anesthesia increased by 50% from 2007 to 2017, reflecting a belief that spinal anesthesia is superior to general anesthesia. I think it comes because of the experience that increasing. Anesthesia choice must be on the preference of the patient, but they have this study have many bias. I will not speak about this, not the time. And another study saying no difference in 30 days major complication between general anesthesia and regional anesthesia. Another study, there is a probability or meaningful difference in most outcome between spinal anesthesia and general anesthesia for hip surgery, for fracture surgery. Time to move forward. A meta-analysis show no difference in outcome between general and regional anesthesia, another one. But all the time, when you look for the study, you're looking for the methodology and the outcome, because different from area to area. And you can see now in this regional versus general anesthesia and older patient for fracture surgery, systemic review meta-analysis. Regional anesthesia don't significantly reduce the incidence of post-operative delirium and mortality compared to GA. Due to limitation of the study, this is a problem most of the study. Again, the same result. Again, no difference between the general and the regional anesthesia. There is a remain, and even some people extend to beyond that. They said there is a remain a role for neoaxial anesthesia for hip surgery. You know, even this question, you know, that general anesthesia, it may be more better than regional anesthesia. There may be benefit of neoaxial anesthesia for after hip surgery. More study about this, about the type of this, and also, you know, against the river, it come and study like spinal anesthesia linked to higher painkiller use, and this study showing that this patient, if he gets spinal anesthesia, he get the 2 months analgesia 33% more than the people taking general anesthesia. Again, another study showing that there is data suggesting regional anesthesia is the preferred technique limited evidence about available, not permitted definitive conclusion, as I told you, for mortality or other outcome. So based on this one, we need a randomized control study. Another study coming against what we believe. Spinal anesthesia for hip fracture, may lower mortality and morbidity, and said that spinal anesthesia compared to general anesthesia for hip fracture surgery may carry fewer risks for the patient for combined incident of stroke, myocardial infarction, or this on 30 days. Some study looking for another outcome, and this study showing that regional anesthesia associated with reduced in hospital mortality, because looking in hospital mortality, not mortality after 30 days, and also that no difference in 30 days. Postoperative pneumonia and mortality is less in regional anesthesia because it may be you don't use an sedation. And also this study, general anesthesia or spinal anesthesia, general anesthesia was associated with an increased rate of the adverse event and mildly increased operating room time against the studies. Also, you're looking at many studies just showing that, but at the end, it will be more or less the technique you like. So the same, this is a study done about the total intravenous geriatric surgery fracture with severe systemic disease and ischemic and regional anesthesia with general anesthesia, what's called the regional nerve block with general anesthesia, and they found a good result, less opioid and more it's called less ICU admission, less stay in the hospital, and but they need more study also. This is another study. As they said that regional anesthesia in a part is a more better than general anesthesia. And which type used for spinal anesthesia? Bupivacaine, hyperbaric, isobaric, or hyperbaric. Hyperbaric bupivacaine 0.5. The problem with that, it works fast. It can give a dense anesthesia, but really it can extend up because in hyperbaric, when the patient sleep and can get a severe hypotension. The isobaric, I use it for a long time. Is a very good choice. Is predictable. Very rare to make an hypotension, but the problem, it can take 15 minutes to 20 minutes to wear. And if you have a block room, it can be a good choice. Hypobaric, the problem is unpredictable, and the failure rate is very high. And this is a study efficacy of safety of 3 different techniques. They found no difference between the 3 techniques: spinal anesthesia, continuous spinal epidural, and general anesthesia, except the narcotic requirement. Adverse effect would happen in the operating room with general. At the end, this comparative efficacy of neuroaxial and general anesthesia for hip fracture, meta-analysis and randomized control study. And I think I believe in this one as a physician, as I work, difference in blood losses between neuroaxial and general anesthesia. I agree with that. And most of studies showing that. Of anesthesia must be based on if you are a professional, because we don't have what's called solid evidence about it. Patient comorbidity different from 1 to 1. This is not one fit all. Potential postoperative complication. Orthopedic surgeon is a very professional, what's called fast surgeon, can make a professional job in short time, and the clinical experience of the anesthesiologist. I can't bring you never doing spinal and you do a spinal for that. And this is a case for epidural versus general anesthesia for the hips arthroplasty. I found a very little amount of study about it because it's an old study also, because it is unpredictable, take a time, sometimes can't make anesthesia for the sacral area, and most of the time you need an catheter and you can't control the patient. Rehabilitation will be very difficult after that. Peripheral nerve block, that there is a many nerve block can be done for the hip surgery according to anterior, posterior, lateral approach. So fascia block is one of the most common use. Being a block, they can give a shoulder for fascia iliaca now and femoral. At the end, fascia iliaca block can reduce spasm because have some more motor effect. I think being a block less motor effect if you give a low volume. And again, below the flat catenaris nerve for the site can be for nailing because you need this area. The problem of hip innervation is very complicated, and you need a multimodal analgesia at the end, whatever you use an regional anesthesia or not. And it's fascia iliaca being a block here, and you see the head. And ultrasound guided block, ultrasound guided epidural. Now, what you are doing by ultrasound the chest, just checking the position of endotracheal tube, and this is coming. And this study came from Hamad Medical Group, from our group in Hamad, retrospective case series, being block combined with femoral lateral cutaneous nerve side as a novel regional anesthesia approach for hemiarthroplasty and dynamic hip screw, and using being block with femoral block. You give 10 mil every place and 5 mil for lateral cutaneous side, and make a sedation for all the patients, and they make about 50 patients, and it was a very good results. I think I read a paper for Dr. Nabil here, but I may lose it. Anesthesia management for hip fracture in pediatric patient and respiratory and heart failure. This is just a case report, and it done excellence in UK, making guidelines to standardize the practice, and timing, speak about timing, and speak about how many hours we need to stay until to make a surgery, different from England to Ireland, but it's about 48 to 72. And I wonder when I looking for this table, because I found, if you make a procedure, take a 45 minutes. And I wonder, because our surgeon take about 2 hours just for positioning of the patient. And also patient and care information, multidisciplinary pain treatment, and have a book, like a brochure for the patient to read all this stuff, to see it, even mobilization. And at the end, it is a teamwork, and also the analgesia after that, and surgical complication procedure, how can you treat it, what you do when you found it, analgesia, comorbidity. And also it came to our case study, as Dr. Nabil said, this is a 90 years old female, and mechanical fall isolated at home, and there is a cause of fall, like her cat. She have a mild dementia, diabetes, mitral infarction 20 years ago, hypothyroid. So live alive in assisted living walk with a cane. So all the time you're looking for the rapidly correctable factors, comorbidity. I can't stay for many days just to correct the morbidity. The outcome become worse. So you are just putting the scale two sides to just to correct as you can to correct, and don't wait more time just to correcting to be optimally. Just you need to be maximum. No, don't need to be maximally. You need to be optimally as possible as you can, but don't delay the patient, because delaying the patient more than 48 hours, you can get a more complication. And unfortunately, this patient, after this delay, she get from 2 a.m. Tuesday, and the operation was done in Friday, and they get a very good result. But this is not all the case all the time. Delaying make a complication. Again, I think it can use an regional anesthesia and general anesthesia, and especially not a very high risk, as we said all the stuff. And you know that Dr. Nabil here speak about cardiac enzyme. Even troponin was going up, double, triple, or become very high. And this is still they're doing the operation because the patient is still stable. And I think I read about it. I found this very interesting thing. It's a very easy test to do this cardiac leg of troponin for ischemia or infarction. But also, if you found it high, you can just go for surgery. And the problem here, we don't use it here, but I'm thinking seriously to use it in our hospital, because I have many cases. And you know that the consultation is very important to prepare your patient and to clear it in OR. But if you don't have any, in the weekend, I don't have anyone just in the hospital, cardiology or echo, it is more wise to get the patient for 48 hours to not to leave him and to take a decision. And at the end, the echo was good. And even that the normal level for troponin is 0.4 nanogram per ml. And that is patient delay and is out of plane. But at the end, I don't know, Dr. Nabil, because I was working today in room 17 also, and we have 3 cases of, I don't know, I know everything about our hospital or not, but, he makes the operation and, succeeded. And, whatever you use are the guides, what is the best for you, the best for the patient, discuss with your patient. And his choice is very important. As I told you, the hospital, by definition, is the house of diseased people. And these diseased people must take an opinion on their house. and he changed from a person who suffered to a customer. And as the Dr. Nabil asking about delay versus maximum optimization, I think you don't need maximum, you need optimal optimization. What you need. So I think preoperative myocardial infarction after non-cardiac surgery and surgery, and you need to correct whatever you can correct: fluid, electrolytes, EPG, heart rate, avoiding myocardial ischemia, and treating sepsis. Medical treatment including antiplatelet, beta blocker, statin, and ACE inhibitor. Risk benefit of antiplatelet against the surgical bleeding, and delayed versus optimization. Usually surgery provide analgesia and reduce mortality and complication, but waiting can make a more catastrophic thing. Analyze from time, and just I go fast like this, and I have what's called self-assisted assessment if you need it at any time, but just I pass this one, and this is my message to you. You know, hip fracture is a journey of physiological impact in susceptible individual. Choice of anesthesia is one factor, but it is a major can affect the major outcome. Both surgical anesthesia and general anesthesia acceptable analgesia for elderly and hip fracture with similar outcome in mortality and delirium. High risk for general anesthesia such as advanced pulmonary disease, spinal anesthesia preferable. Spinal anesthesia tend to decrease opposite mortality. It's the same what we said, decreasing the opposite nausea and vomiting, delirium. It's maybe because of unsafety of the drug intrathecal must be located. More study will improve. And to give an other data is my reference. And thank you very much. But still, many questions not answered. Thank you very much.
Thank you very much, Dr. Yasser, for this rich presentation. And just allow me to remind you, please just put all the questions to the chat area, and we're gonna reply all of them by the end of the presentations. And now please allow me to go in another deeper dive with Dr. Nabil for the bread and butter of this presentation. Dr. Nabil, it's all yours, please.
Thank you, Dr. Yasser. Okay, so in that part of the presentation, what we are going to be talking about is the analgesia. So far that you heard about the preoperative workup, you heard about what is the optimal anesthetic, and now what we're going to do to help this patient with their pain. So the title of that talk is Regional Anesthesia or Blocks for Hip Fracture, the Golden Circle Approach. And you may be under the impression that we're going to be describing a new approach for different blocks for hip fractures, but you're going to see very shortly that this is not the case. This is where I currently work. I moved to University of Virginia about 16 months ago, so not too long ago. And before that, I used to work in Philadelphia at the University of Pennsylvania for the past 13 years. These are my disclosures. And over the next 40-45 minutes, we're going to discuss the nerve block techniques that we use. And we are going to essentially say why. Why do we need them? And also that we are going to just go through an analgesia protocol or a pathway for hip fracture and trying to put the whole thing together and how to care for these patients in the preoperative period. So this is a vignette that we have seen before. I don't know, how many people, if you can Google, who Simon Sinek is. So Simon Sinek, he is an American author. He was born in the UK. He's a motivational speaker. He talks about coaching, and he's an executive coach, and he really has very nice TED Talks on YouTube. He had a couple of books that you can find them on the internet, and one of the books is one of the things that he always preach is what we call the Golden Circle Approach. What is a Golden Circle Approach? It's essentially how do you think about things, and the way that you think about things, you think about them as an individual or organization. You think about them from the inside out. So always start with the why you do what you do. If you are thinking about everything that you have listened and you will listen to today, whether it's the preoperative workup, whether it is the choice of anesthetic, or whether it is the choice of a nerve block for a hip fracture or for any other surgery, Like if you start by the why and you are convinced, like, why are you doing this? And you have a very good reason, I think everything else is going to fall in place. In terms of the how and the what, which is essentially the technique and what do we use, I'm sure that we're all can be taught and you can learn it in like, so many different settings. But again, just like, this is really like, what I would plead with every one of you to think about. Why are we doing like, this, and why would analgesia, especially peripheral nerve blocks for these patients, are of utmost importance. You may have heard some of the statistics during the talk that was given by Dr. Wissam. And just to summarize, about 300,000 people in the United States, and worldwide, like, annually, 1.6 million people would suffer from hip fracture. And by the year 2050, and you've seen the graph for that, about 6 million people are going to be suffering from hip fracture per year. And it seems that this is the disease of women more than men. And the incidence, as you see, it's about 1,000 to 100,000 for women, and for men, it's about the half or less than half. The mortality at 1 year, 25% of these patients are going to die, and 50% of them who lived independently before the hip fracture, okay, they're going to be in a nursing home by the 1 year mark. Nearly all hip fracture patients require surgery and anesthesia. And also that you have heard from Wissam and from Dr. Yasser, pretty much the non-surgical treatment of hip fracture is almost a death sentence, like, for these patients. Well, I can tell you at some point that we did, when I used, like, way back when, like, ages ago, when I used to work in Egypt, like when this patient, they put this patient in traction, the patient is 90 years old, and it's almost literally a death sentence, because this patient is going to develop, like, DVT, they're going to develop PE, and eventually they are going to die. And even in cases that they have a lot of comorbidities, or they have even paraplegia or hemiplegia, sometimes just the main indication for the surgical repair is the pain and how much pain this patient is at, and to alleviate the pain that they have to go under surgery. I tried to look for some statistics to essentially just make it more relevant to the audience, and I can only find some statistics for hip fracture from the Cameroon and from Morocco. And it seems that the incidence in these countries are much less than it is in the United States. And this can be either because like, inadequate reporting, and really we don't have, like, adequate statistics, or maybe it's just, like, the nature of the population. Maybe it's different. Maybe people do not have as much osteoporosis. I mean, honestly, I am not sure, but this is what the literature say. It's a little bit old, over 10 years ago, but this is what I was able to find. And the numbers just go on and on between different countries and the incidence of geriatric hip fractures. So the bottom line, okay, this is almost a health population problem. And this is something that is going to affect pretty much everybody where they practice, whether you practice in the UK, in one of the Gulf countries, or in the US. And also we care because the undertreatment of acute pain may be associated with delirium, cognitive dysfunction, pneumonia, decreased mobilization, DVT, and pulmonary embolism. And ultimately, they may affect the patient physical rehab and their ability to perform their active daily living. So before the hip fracture, they lived independent. They were doing, like, whatever they need to do. After the hip fracture, now they become dependent on their family, and there are a lot of social determinants that can result in that. The advantage of regional anesthesia, this is probably something I feel that I'm going to be preaching to the choir here, but you can say it will decrease the opioid requirement, and with that, there's going to be a decrease in the opioid-related side effects. It's going to decrease the stress response to injury, and it's going to improve the neurological assessment, especially if you are trying to do that in the perioperative period. There are a lot of studies that is showing decreased length of stay in the hospital and also in the emergency department. And as Dr. Yasser alluded to, it's associated with decreased cost. Now, just think about that scenario. You have grandma who's 92 years old, and she fell, she came to the ED, and she's complaining of pain. And the first reaction, the first knee-jerk reaction that's going to happen, the ED physician is just probably going to give her 2 or 4 milligrams of morphine. She's going to be comfortable, she's going to be sleepy, but by the time she wakes up from that, she's going to start to be confused and she's going to start to have delirium. And it's almost, she's going to be spinning into a downward spiral. So contrast that with another scenario that she comes to the ED and you start to give her, like, you know, another alternative other than opioids. I think the outcome may be very different. Also, that we have the phenomena of the oligoanalgesia. So we say the undertreatment of pain is bad, but this is a study from a lot of the emergency department in Australia, and they found like the time lapse between the patient admission to the first receipt of any analgesic medication was over like 2 hours. When we said that we're going to start thinking like Simon Sinek and we're going to talk about the why. So when we talk about why and why regional anesthesia is important, we have some evidence to support that. So this evidence is coming mainly from societal guidelines, and some of the guidelines you see from a lot of the authorities and just government agencies in the United States and the UK. And we're going to try to go through this in a nice way that's not going to be very boring like for you. So the Agency of Healthcare Research and Quality in the United States, they put a statement, they essentially they review the literature and they're looking for the different options for preoperative management. As you see, this is the rating of evidence here. The 3 dots are going to be something that's going to come with high evidence. The 2 dots is going to be something that's going to be coming with moderate evidence. And when it comes to hip fracture specifically, you're going to find the things that have really the moderate evidence is not a lot, but when you look at nerve blocks, that nerve blocks actually is very well supported in the literature, the benefit of them. And you would see that, especially when it comes to delirium, the number needed to treat, they estimated that as 9. Okay, what else? This is a Cochrane review. You probably are all familiar with what the Cochrane review is. And it's essentially, it's another agency that is very much tasked with review and analyzing the results of randomized clinical trials. And there was multiple iteration for this Cochrane review, especially when it comes to peripheral nerve blocks for hip fractures. It started in 2014 and they updated every couple of years. So one of the updates that was in 2018, and at that time that they had 8 trials. And what they found that peripheral nerve block reduced pain on movement within 30 minutes of administration of the peripheral nerve block. And they found signals that pneumonia is less and reduced time to first mobilization and also reduced cost of the analgesic regimen. Fast forward a couple of years, there are more trials also that was included in another update from the Cochrane review. So instead of dealing with the 16 trial that we dealt with, now we're dealing with 49 trials, and the number of patients jumped to over 3,000 patients. And the signal was even more stronger for decreasing the pain during mobilization. And actually, this was like the first time that they found that there is a signal for decreasing acute confusional states with the administration of peripheral nerve blocks in patient with hip fractures. And this plot or this graph that you see on the screen, all the blue dots that are falling within this curve, this is essentially showing beneficial effect for the administration of peripheral nerve blocks in terms of prevention of the acute confusional state or simply delirium. Okay, so this is all randomized clinical trial that may be done with anesthesiologists or group of anesthesiologists, and they may be biased. What about the American Academy of Orthopedic Surgeons? Let's see what are the guidelines that they put out. So they put out a summary for the guidelines, and as you see here, I'm going to put red circle on the things that we may be involved in as anesthesiologists in the care of these patients. So as Yasser alluded to, you see that like between spinal and general, they did not make any definitive statement. But when it comes to multimodal analgesia and nerve blocks, they strongly recommend that. They also talk about the use of the tranexamic acid and the no delay for surgery. So this is all on the US side. What if we cross the ocean? And we talked about the evidence from the UK side. Well, you have the National Institute of Healthcare Excellence, and actually they put together a very nice database for hip fracture. And their guidelines is essentially for immediate assessment of these patients, as Wissam, said, analgesia within 30 minutes, sufficient analgesia, that is, and they recommend the acetaminophen nerve blocks. However, in this iteration of the guidelines from the UK, the non-steroidal anti-inflammatory were not recommended. They also put update on their website about how much compliance of the different hospitals with the guidelines that they put. And you can see here that almost 70% of the hospitals in the UK are compliant with these guidelines. The Prospect is another group that is very interested in analyzing the different analgesic modalities for the different procedures. And this is sponsored mainly by the European Society of Regional Anesthesia and Pain Therapy. And this is very recent. I don't think it's in print publication yet, but you can see here they also recommended the multimodal analgesia, the acetaminophen, the non-steroidal, and a single shot of nerve block. And of course, they acknowledge that there is a potential contraindication for some of those in the fragile patients. So I hope that we were able over the past 10 minutes to make a case for you for the why. Why is administration of peripheral nerve blocks in these patients are very important. So this is essentially how we are thinking about this. We're thinking from the inside out. So now we know that they are important. Now, what are we going to do with that? Now we're going to talk about the how, and we're going to talk about the what, how we're going to do this, and what techniques we're going to choose. But before we jump with both feet into the different type of blocks, as Dr. Yasser also kind of alluded to in a way or two, that hip fracture is not a hip fracture, is not a hip fracture. Hip fractures are not created equal. What do I mean by that? This is the different classification of hip fracture, and you're going to see here there is a femoral head fracture. There is a fracture that can happen between the two trochanters, that's intertrochanteric fracture, and there is a fracture that can happen even in the neck of the femur. And with these different types of hip fracture, if you look at the graph on the right side, some of them are going to happen outside the capsule of the hip, which is going to be right here, and some of these fractures are going to happen inside the capsule, whether it is something that is going to happen for the femoral head, or if you have a femoral neck fracture, okay, it depends. And why are we saying this? Because this is going to pretty much affect our choice for the anesthesia, and we have to understand what blocks are we using for that. It gets even more complicated with that. So it gets more complicated because the types of repair for the different hip fracture are very different. And you can see from going from the left of the screen to the right of the screen, a patient with cannulated screws, very different from a DHS or a dynamic hip screw, versus a nail, versus a hemiarthroplasty, versus a full hip arthroplasty. So you have different type of fractures, you have different type of surgical insults, and we are trying to fit our techniques, our regional anesthesia techniques into those. So this is essentially an invitation to think right before you just offer anything. Think about the why and think about the what. What are you going to be offering to that patient? So with that, I think it's going to be prudent to just review quickly what is the nerve supply for the hip. If you think about the capsule of the hip, all right, and you divided the capsule of the hip into 4 quadrants, you're looking at the capsule of the hip right here from an anterior view, and on the right-hand side, you're looking at the posterior view of the capsule of the hip. So if you divide, the hip joint into 4 quadrants, you're going to find that there is actually dense concentration of both the nociceptor and the mechanoceptor in the anterior capsule of the hip. And the anterior capsule of the hip is going to be mainly supplied by the obturator nerve, or the branches of the obturator nerve, branches of the femoral nerve, and branches of the accessory obturator nerve. If you look from the back or the posterior capsule of the hip, it's going to be branches mainly of the sciatic nerve, whether it is the superior gluteal nerve or the nerve to the quadratus femoris, and some tributaries from the inferior gluteal nerve. Okay. Another way to look at it, this is the different nerves. And again, to be consistent, this is the anterior part of the capsule of the hip, and this is the posterior part of the capsule of the hip, and this is the different nerves. You're going to see mainly the femoral and the obturator, and here you're going to find the sciatic, the nerve to the quadratus femoris, and the superior gluteal nerve. So it looks like at least from this review, mainly the anterior capsule, if we have to focus on something, maybe that we're going to focus more on the anterior capsule rather than the posterior capsule, realizing that probably our blocks in that case is not going to be complete. So what if I want to do like, a complete block? If you want to do a complete block, whether you are able to do or not because of the coagulation, because of the patient condition, physical condition, and the comorbidities and positioning and everything, I mean, honestly, the one thing I can think of that's going to give you a complete block is something like an epidural. But it's almost becomes very difficult, especially in patient with hip fracture, for a lot of reasons, okay, that we can talk about. But to just summarize again what we talked about, the supply for the hip is going to be mainly from the lumbar plexus and the sacral plexus. And this is not going to be new information for you. The lumbar plexus goes from L1 to L4, and the sacral plexus is going to go from L4 to S3. The major products of each one of these plexi in the lumbar plexus is going to be the femoral, the obturator, and the lateral femoral cutaneous. For the sciatic, it's going to be, for the sacral plexus, it's going to be mainly the sciatic, and the sciatic is going to give like a lot of the branches. Okay. I hope that we're clear so far, all right? And again, I personally, I'm a fan of the anatomy. You can describe me as anatomy geek or nerd, all right? And I essentially, this video, we can just go through the anatomy as if we are in a cadaver lab, all right? I'm gonna just give you some orientation first. The left hand of the screen is gonna be the head of the patient. The right hand of the screen is gonna be the leg of that patient, and all the abdominal organs has been retracted, and this is essentially the posterior abdominal wall. And on the posterior abdominal wall, the first nerve, this flat nerve that you are looking at right here, this is going to be T12 or the subcostal nerve. All right, we are going to retract that up, and then we're going to pick up L1, and L1 as it goes down is going to divide it into the iliohypogastric and the ilioinguinal nerve. We're going to move even farther down on the lateral side of the psoas muscle, which is right here. This is going to be the lateral femoral cutaneous. The lateral femoral cutaneous comes from L2 and 3. As you can see, it's going to come from the lateral side of the psoas, and it's going to go through the pelvis, and it's going to cross the inguinal ligament, and it's going to show up on the anterior side of the thigh, and it's going to be living between the sartorius and the tensor fasciae lata, and it's going to supply the lateral part of the thigh. This muscle that you see here, this is the psoas major, and the nerve that we're picking, this is the genitofemoral nerve, and probably the utility of that for our discussion today is very, very limited, but just this is for the sake of completion, know that it's going to have a genital branch and the femoral branch. We're going to retract the psoas laterally, and on the medial side of the psoas, right here, you're going to find this is the obturator nerve that we talked about, and it's going to emerge on the medial side of the psoas. And again, it's going to go below the inguinal ligament, and it's going to give an anterior branch and a posterior branch, and it is going to be divided. This anterior branch and posterior branch is going to be divided by the adductor brevis. They're going to live anterior and posterior to the adductor brevis. We're going to go back up to the pelvis, and you're going to find, the major branch of the lumbar plexus, which is going to be the femoral nerve, and the femoral nerve almost live inside the substance of the psoas major. This is going to what we call the psoas compartment, And as it goes down, this is going to be the artery right here. And you're going to find the femoral nerve, this flat structure, okay, that's lateral to the femoral artery. And it comes under the inguinal ligament, and you're going to find that it's going to start to branch, gives like a lot of branches, including, of course, like branches to the hip and the hip capsule. It's going to give a lot of muscular branches to the foreheads of the quadriceps, and also is going to supply both the knee and the hip. So at least now that we know what we're talking about when we're talking about blocking the branches of the lumbar plexus. I'm sure that you're all familiar with the concept of the dermatomes and the osteotomes and what is supplied. The sensory nerve supply of the skin is very different from the sensory nerve supply that is supply the joints, that supply the bones, and supply the muscle that that's controlling the joint movement. And this is a concept of the difference between the osteotomes and the dermatomes. Okay, so what are our approaches? Remember that we're trying to put this in the context of how we think about things. So we started with the why, and then now we're talking about the what and the how we are gonna just combine them together. What blocks are we offering and how we're offering them? So the first thing is the lumbar plexus block. Yeah, I mean, at some point that used to be like a very popular technique. We used to do it a lot, like with the nerve stimulation. Also, when the ultrasound came about, there was a couple of description of how do you do that with ultrasound. This is going to be the vertebral body, in that this is the position of the ultrasound probe. This is going to be the vertebral body. This is the transverse process. And this is here, this is going to be the quadratus lumborum, the psoas major muscle, and the erectrospinae muscle. And as we know, the branches of the lumbar plexus, as we've seen from the anatomical description, is going to live within the substance of the psoas major muscle. So this is going to be our target right here. So it can be done. This is what we call the shamrock appearance, or the three leaves of the plant. If somebody is very interested in the Irish culture, this is the good luck charm for the Irish, right? Another approach for the lumbar plexus, if you, with ultrasound, if your probe is in a sagittal plane and you're looking at the transverse processes, and this is what we call the trident appearance. And in the trident, you're going to find the psoas major muscle is going to be between the transverse processes. And you can drop your needle and an out-of-plane technique. And when we used to do this, we used to combine it a lot with nerve stimulator as well, to just make sure that we are close to the lumbar plexus. This is a deep block. This is not a block for somebody who is not very comfortable with the ultrasound, and it requires maybe a moderate to high skill set. It's a deep block. It has complication, including but not limited to bleeding, kidney injury, and you're mainly affecting also the muscle, you're affecting the quadriceps. So falls is a big deal. And what we found in some cases, that when you actually inject medially, or you inject high volume of local anesthetic, you can get some epidural spread. And this is essentially takes a procedure. Let's say that you're doing this for whatever, for a hip arthroscopy or something, that there's going to be some epidural spread, and that may or may not be desirable at that point in time. Do we have alternatives? Yes, we have alternative. How about if we're trying to approach the same branches of the lumbar plexus, but we're going to try to approach it in a way that's going to be more user-friendly and relatively easier? How we're going to do that? How about if we approach the same nerves of the same branches of the lumbar plexus, but we approach it in a more superficial way? So what you're looking at, this is the anatomy of the area of the pelvis. So this is the psoas, this is the iliacus muscle, and together they form the iliopsoas muscle. And the branches of the lumbar plexus, this is the iliopsoas muscle that we talked about, and the branches of the lumbar plexus, these are the stains in the purple. So this is essentially going to be the LFC, the lateral femoral cutaneous. This is going to be the femoral, and the obturator. So how can I get like, you know, the three nerves if I want to get like, you know, a good block that's going to be equivalent to the lumbar plexus block? Well, the idea is if I injected high enough volume in the fascial plane that is covering the iliopsoas muscle, whether I approach that from below the inguinal ligament or above the inguinal ligament, there's going to be a cephalad spread of that local anesthetic, and it's going to cover like, you know, the three nerves as you emerge from the lumbar plexus. And this is essentially the concept or the idea behind the fascia iliaca compartment block. You can do that with ultrasound. You can do that with landmarks. So if you do that with the ultrasound, you're going to find this is going to be the sartorius, this is going to be the iliopsoas, and below the sartorius is going to be the fascia iliaca, right here that I'm pointing at, and with the three arrows. And you can deposit your local anesthetic to push down the iliopsoas muscle, and that will aid the spread of the local anesthetic when you inject higher volume to go up and or cephalad and cover the branches of the lumbar plexus. The nice thing about this block specifically that it lends itself to multiple techniques. What do I mean by that? Let's say that, like, you know, somebody in the audience today can say, like, Nabil, you're talking about like, you know, blocks. This is like, you know, very fancy. I'm not comfortable with ultrasound. I don't have ultrasound in my hospital. I work in a low resource setting. I said, okay, great. What you can do, you can offer this patient also the same service without actually using ultrasound, because it lends itself to landmark techniques. If you remember, those of you probably my age, like remember the fascial clicks, and when you go through the skin and you go through the the two pops, and then you inject the local anesthetic, this is essentially can be your fascia compartment block or fascia iliaca compartment block, or it can be in a way the poor man femoral nerve block, even if you don't have an ultrasound. And meanwhile, you're essentially just offering your patient an alternative, especially frail patients with hip fracture, even in something that's going to be that a low resource setting. That's why, like, you know, I just choose this is almost the word simplest idea, especially that we went through the evidence and we have strong evidence to support the use of regional anesthesia, that it will improve postoperative pain control and possibly delirium in these patients. Unfortunately, there was a study that we looked at that is now a couple of years old in the Optum database. Optum is a pharmacy and billing database, and we looked at about 80,000 patients with hip fracture from 2004 to 2015. And unfortunately, the incidence of patients, okay, who were offered peripheral nerve blocks in hip fractures did not exceed even like 5% of these patients. However, just the percentage of offering, like, you know, these techniques is very variable depending on where you are. There are some studies from Canada, especially from the province of Ontario, about the incidence about 18%. In the UK, that rate goes like, you know, a lot higher. It's about 50%. This is essentially a relatively easy to do based on different settings and different operators. So what we tried to do, like, you know, in my previous institution at the University of Pennsylvania, we tried to really get our services up to snuff. So we have anesthesiologists with experience in regional anesthesia during the normal business hour from 7 to 5. After hours, some anesthesiologists are not very comfortable with ultrasound. And also remember that the other thing that some of these patients would come to the emergency department, and some of the emergency physicians, some of them are comfortable with ultrasound, some of them are not comfortable with the ultrasound. So how can we really increase the adoption of peripheral nerve blocks for these patients? So what we did, we printed laminated cards and we attached to the side, to the back of each machine with a sample of the anatomy, like, you know, of that block. And actually on each of these laminated cards, we prepared a kit. That kit has essentially all the supplies that you need, like, you know, to perform these nerve blocks. So if one of the anesthesiologists or one of the ED physicians who come and they need a refresher course, what they do, They pick the ultrasound, they drag the ultrasound, they look at the laminated card, and each one of these laminated cards has the QR codes right here. And once they scan the QR codes with their phones, that's going to take them to a video tutorial. That video tutorial is about 2 or 3 minutes each. And one of the QR codes is going to lead to the ultrasound technique, and the other one is going to lead to the landmark-based techniques. So this is just real quickly, just going through, this block. I'm just going to fast forward a little bit, right? But essentially, this is what you are going to see in offering of that nerve block, the fascia iliaca with ultrasound. We feel where the artery is, we scan the groin area, and just we move the probe lateral, right? And then we numb up the skin, and you're going to see the ultrasound image in a second. And this is going to go through the implant technique. This is the infrainguinal approach to the fascia iliaca. You see the femoral nerve, the femoral lateral to the femoral artery, and we're going to move lateral. As we move lateral, you're going to see the sartorius on the top of screen and the iliopsoas muscle. And the needle is going to be approaching from the left side of the screen, and it's going to go through the fascia iliaca. And once it's through the fascia iliaca, you're going to see almost the unzipping of that fascial plane. And this is a little deeper. Now this is in the correct plane, and you're going to see the separation, the clear separation, and the pushing down of the iliopsoas muscle. And hopefully it's the function of the volume. And as you see, the more volume that we inject, that separation becomes wider. What was our results after implementation of this? Actually, our uptick or the adoption of the block has increased from 10% in 2020 to about 48% in July of 2023. However, there are still some problems with this approach. What are these problems? Anesthesiologists usually, you can say, well, this is what we do. Why do I teach somebody else how to do blocks? Why do I teach an emergency room physician to do blocks? Why do I teach someone else? Because if you're not available 24/7, maybe it's going to be a good service for the patient to teach someone how to do these blocks. The other thing is, as you know, that the teaching and education materials are available now, are readily available on YouTube, on workshops, on a lot of resources. And if you did not take the leadership and the ownership of this training, somebody else will. But also, on the other side, from the emergency room physician, that they are trying to adopt something that they are not very familiar with. And if there is any liability or maintenance of competence, this is also something that we have to think about as we put these programs together. And this was a study that was not a study, it was a review article that was put together by a couple of our colleagues, just talking about offering of regional anesthesia by non-anesthesiologists and what are the things that we should be thinking about when we do that. After I moved to UVA, also that we try to track our data, and this is going to be something that that probably is going to be interesting. You see there over the past 5 years, this is how much we offered neuroaxial anesthesia and general anesthesia, and pretty much our offering is consistent. Okay, over the past 5 years, you see uptick in the offering of regional anesthesia and the decrease in the general anesthesia, and you're going to see by year the number of cases that we offered in our own institution at UVA. When it comes to peripheral nerve blocks, this is essentially what we did. This is, again, that we're looking back. This is 10%. Right now, I'm relatively new to the institution at University of Virginia, and we're trying to put a program similar to the program that we did at the University of Pennsylvania to hopefully just get this number up to maybe 60 or 65%. And maybe that when we talk about this in the future, that we can have better numbers for you. But the message why I'm putting these numbers here, because it's going to be very important for you to know your own data and to benchmark what you do against others, because this is what's going to help you develop, what's going to help you put programs together to improve your preoperative management of these patients. This is actually, this study just came only this year, only a couple of months ago, and they used an experience that is very similar to what I talked about, the experience with our experience at University of Pennsylvania. They looked at the barriers for the wide implementation of peripheral nerve blocks, and they divided these barriers into about 18 barriers, and they categorized them into the categorization of education, persuasion, training, and they proposed ways to overcome these barriers, and they put programs together, and the result was they have two cohorts of patients before and after the implementation of the protocol that they did. This study came from Canada, by the way, and there was an increase in the uptake of the fascia iliaca compartment block from 48% to 65%, and with that, the incidence of delirium went down from 43% to 34%. However, there was a similar opioid use between the two groups, and the time to administration of the nerve block, with actual from the admission to the emergency room till offering the nerve block, was decreased as well. Okay, how about if we want that local anesthetic to really spread even more cephalad, and I want to avoid just giving that very high volume of local anesthetic? So I think logically that would say that I should put my local anesthetic even higher than what? Higher than the inguinal ligament. So what that will be? That will be the suprainguinal fascia iliaca block. Let's see how this is going to work. This is going to be the sartorius. This is going to be your inguinal ligament, and this is going to be your abdominal wall. So how this is going to look if you put your ultrasound probe as such, what you're going to see what we call the bow tie. What is the bow tie? The bow tie is going to be the sartorius is going to be towards the patient feet, and the internal oblique is going to be towards the patient head. And this is, you're going to see the ASIS right here, and you're moving your probe medially, and it just taken that position, almost pointing a little bit towards the umbilicus in a kind of a tilted sagittal way, but not completely straight, that you're going to see both muscle, and you're going to see the fascia iliaca, but that way that you're putting your local anesthetic in the same fascial plane, but much more superior, okay, to the first position of injection. How this is going to look like in that video is going to look something like this. Okay, you're going to see this is, so the video is going to look like this. So this is essentially the needle is coming from caudate to cephalad. This is the fascia iliaca. This is the artery that we should be aware of. And you see the very nice spread of the local anesthetic. And this is the correct pattern. This is very important because you want the local anesthetic to really spread in the fascial compartment desired, and you want local anesthetic to spread high. We can argue all day about what nerves are involved and whether it is landmark guided or ultrasound guided with the fascia iliaca block, and whether the obturator is going to be involved or not, because the theory, especially with the infrainguinal fascia iliaca block, that there is fascial compartments that are going to prevent the spread of local anesthetic to the obturator nerve block. And you have seen in the sensory nerve supply of the hip how important that is to the supply, especially for the anterior capsule of the hip. But again, the evidence when we use ultrasound, I mean, it's suggested that actually the spread to the obturator nerve is going to be improving, and the odds of improving almost doubled. All right. You do fascia iliaca, whether you do fascia iliaca suprainguinal or infrainguinal, you are bound to get the femoral nerve. You get the femoral nerve, you're going to get motor weakness. All right. I want to do a block that's not going to result in motor weakness, and it's going to just give me the same degree of analgesia. How about if I went even farther down and I tried to get to the branches that is going to supply the capsule of the hip? So, and that was a description of the pericapsular nerve group block, or what we call the ping block. It also may help, the guy who described, this compartment block, his name is Philip Ping. So it was really, a nice commemorization of, him. It become, the ping block. And the way it works, that the branches that supply the anterior capsule of the hip, especially from the high femoral and the high obturator, they're going to live in that compartment between the anterior inferior iliac spine, and this is the pubic eminence. This is the tendon of the psoas. And if you deposit local anesthetic, like, around this area, and you tilt your ultrasound probe a little bit, like, caudate, you're going to find yourself, you're looking directly as here to the capsule of the hip. And essentially, you're putting the local anesthetic around the area, which is the terminal branches that supply the anterior capsule of the hip. And it's going to look something like this. Again, this is coming from lateral to medial. The needle is coming through the iliopsoas. You see the femoral artery on the left side of the screen, and you're going to see the local anesthetic deposited around the pubic eminence, and it's lifting the tendon of the iliopsoas, like, from the bone. Can it be used for hip fracture? There is one study that came out in regional anesthesia and acute pain medicine. It was a case series about 5 cases, and actually they are saying the answer is yes. Okay, it results in improvement of both the static and the dynamic hip scores in hip fracture patients. However, one of the fallacies of that, remember when we talked about the different types of hip fracture, and there is intracapsular and extracapsular hip fractures. Now, no mention of what that is, and whether this is going to be something that just what type of hip fracture that is. This was the case report that was done, and then after that, now they are talking about the pen block for early pain management in hip fracture patient, and again, pretty much very similar results. They did the study, but there were no comment whatsoever on what type of hip fracture and whether this is intracapsular and extracapsular. And maybe this is just a call, for each and every one of you to just think about, when you design a study like this, that there has to be a description of the surgical insult, there has to be a description of the type of repair, there has to be a description of the type of fracture, at least to provide that consistency in the evidence that we generate. Other fancy options that probably not very much practiced frequently, but it's possible. It has been described in case reports and case series. The ESP, the retrospinal plane block, very much the block that now it's you choose a procedure, whatever that is, you name it, and they use the ESP for it. The evidence is still not very solid to support the administration. The quadratus lumborum block, especially, it has so many variation of the quadratus lumborum, including the lateral, the anterior, and the posterior quadratus lumborum. But mostly here, they are referring to the anterior version of the quadratus lumborum when the local anesthetic is deposited between the quadratus lumborum and the psoas muscle. You probably realize from the accent, and you probably, some of you know who I am, that I was born and raised in Alexandria, Egypt, and we're very allergic to pain. And the way that we deal with pain one block at a time. The most important part that I would really want to deliver, from this, that it is not about the block itself, and it's not about, the type of anesthesia in isolation, and it's not about ordering an echo or not ordering an echo. It's actually about how to put everything together in a pathway to take care of these patients. This is going to be the pathway. This is going to be a protocol that we have to put together. Again, when I was at the University of Pennsylvania, we had that concept of a disease team, and the disease team put together the hip fracture pathway that essentially it just takes the patient from the minute that they are admitted to the emergency room department until their discharge, and even follow up after discharge. So the mission was to provide coordinated care for geriatric hip fracture patients from the point of entry into the health system through the recovery. This is a very complicated map that you can tell, but each one of these boxes is a touch point for that patient, from their admission, from them coming to the ED, all the way to their discharge, and even just to follow them up, like, after discharge and their disposition. And essentially what it calls for risk stratification. It's called for co-management with geriatrician or hospitalist on the floor. It calls for careful consideration of the anesthetic choice. And in my mind, the best anesthetic choice is the anesthetic choice that you can deliver well in a competent way, that you are very comfortable with, and it's going to be a good fit for that patient and also fits the normals of practice in that institution. As much as possible, like, try to work with your surgeon to really decrease the time from admission to the operation and prioritize these cases in the OR schedule. Use peripheral nerve blocks as early and as frequent as possible. Use antifibrinolytic, that's TXA, and also create standardized protocol for multimodal analgesia throughout the hospital stay to avoid undertreatment of pain. Because it's not because the patient is elderly and frail, you just withhold the opioids, because also undertreatment of pain is probably can be as worse as the given opioids and the side effects that can result from administration of these opioids. That results from a standardized ordered sets that essentially that patient had, like, once they are admitted, and also have the physical therapy and the early mobilization program work with these patients as early as possible. Data is always powerful, that we try to capture, like, this is from, again, my days at Penn. You're going to see this is a system dashboard that goes by month, and you're going to see here the number of cases, time for surgery, length of stay, all the data and the parameters. This is just from your everyday practice. And this is how can you benchmark that against, like, national database, and how can you benchmark, and this is going to be your guidance to improve, like, what you do. Some of this data that comes in this dashboard is going to be the volume of cases, and you're going to see here this is month after month. It's going to include, like, time from admission to the ED to the OR, and again, this is average, like, month by month, and we're going to see this is the threshold for us that we try to meet the 24-hour threshold, and we're going to see if 1 month like we didn't do very well, what can we do the next month to improve, like, what we do on a day-to-day, the average length of stay of these patients, because our goal was to try to do it in about 3 days or less. Now, even discharge, is this patient going home? Are they going to a nursing facility? Are they going to any other facility that would help them with rehab? And even, like, something like the nerve capture. And you're going to see here, like, actually the jump before and after implementation of the protocol. This is, like, how many blocks that we used to do for this patient, and this is how many blocks that we did afterwards. I hope that was not, like, too intense or too much for everybody. Thank you very much. And with that, I'm going to stop sharing. And I think this is going to be all now, Dr. Yasser and Dr. Sahar, that they can essentially lead the discussion for the rest. And I'm going to be happy to take any questions, so as from any one of you. And again, just please put your questions in the chat, and just thank you very much for having me.
Thank you very much.
Thank you, Dr. Nabil.
Thank you, Dr. Nabil. Thank you.
It was an amazing lecture that we enjoyed from A to Z. As mentioned before, it's very, very nice and informative and very organized. Thank you very much. So now the floor is open for the questions, and I would like to start the questions, if you allow me. What are the main risk factors to change the pain from an acute hip fracture to a chronic hip fracture? Chronic pain.
So yeah, I can just take a stab of that. So this is a very important question. Thank you for bringing that up, Dr. Yasser, because this is very important, not only for hip fracture, but for a lot of the things we do. Talk about, like, thoracic surgery, talk about breast surgery, talk about hernia. This is what the term, as we call, the chronification of pain, or the persistent postoperative pain after surgery. And there are risk factors that you can identify in some patients, that some of these patients are going to be at higher risk to develop, like, chronic pain or chronic persistent pain after surgery. If a patient is coming and they are already taking opioids, if a patient is coming and they have any of the chronic pain syndromes, if a patient is coming with a chronic pain condition like chronic regional pain syndrome or something of that nature, these patients are really at risk for developing chronic postoperative pain. However, honestly, like, for hip fractures, I am not sure, like, that there was an extensive work that was done in that regard, especially for hip fracture. I think I've seen most of that work is done with just the joint replacement, hips and knees, like thoracic surgery, breast surgery, and hernia operation. In terms of the hip fracture itself and the chronification, also remember, like, most of these patients, they are elderly and they are frail. And I don't know, like, maybe, like, Dr. Yasser, like, and Dr. Sahar, since they work in, and you yourself, since you do chronic pain, like, maybe you're going to be able to answer that question better than I do. I'm going to be very interested to hear your experience.
Yeah, I have a comment about, I'm just working in my clinic in orthopedic center, bone and joint center. So in my clinic, about 22% or more of the patient came from BPP, persistent postoperative pain or chronic postoperative pain. And it's very common in surgery. And sometimes I feel that the operation is not done to relieve the patient, it's done to affect the patient. And one of the risk factors is the psychological issues like catastrophization, depression before surgery. Another risk factor if the reason for the operation is the pain itself. And there's a concept of preventive change from preemptive analgesia to preventive analgesia. Don't treat the patient to go operation with a severe pain. And I think being a block at work for many people, I have many patients in terminal care for a fracture, but not for surgery, terminal cases. And I make a being block at kind of leave the patient even for 2 months, 3 months, pain relief for one just injection of being a block. And I think the mechanism of acute pain is totally different from chronic pain. Chronic pain is not continuous acute pain. It's different in everything. So the aim of management is totally different from aim of management of acute pain. So thank you, Asher, for this question, because there is an issue, because I'm just make a loud sound for my colleague to care about this patient, to treat it. And one of the most common predictor is the immediate postoperative pain. If you have a postoperative pain and severe pain not treated in the right way, this is one of the predictor for the chronic pain. And I think, this is a subject, a big subject about this, and this is what I can just say about it.
Thank you, Dr. Yasser. Now, Dr. Sahar, please.
Thank you, Dr. Nabil, Dr. Yasser, and Dr. Hussein for this valuable webinar and talks. We have a lot of questions, but can I ask one question by myself? If you want to do continuous fascial iliac block, is it possible, or we are just need to do repeated injection? If we are starting to do it, the ED, and then it will the span of it finished. Shall we better to do continuous put catheter, or is it better to repeat it?
Yeah. So the simple answer is you can. Honestly, you can do anything, right? You can do anything, but just like whether you want to do that or not. So two things. A, like when you put the catheter, if you're gonna put that before surgery or after surgery, if you're gonna put it before surgery, think very carefully about the surgical field and how you're gonna avoid your catheter being the surgical field. So, and there are ways to do that. You can put it and you can tunnel the catheter medially and just do a tunnel catheter and just get it out from the medial side. That's number one. Number two, if you want to use a catheter, maybe just you're better off doing that catheter post-op, because now that they have done the surgery, you're out of the surgical field and you don't have to worry about that. There are some pumps now, infusion pumps, that actually what it does, as you know, and as we have alluded to, this block, this is a fascial compartment block. What does that mean? That this is volume dependent. So maybe put in the catheter and they're going drip, 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 drip. Maybe this is not like, the best option for that type of block. So what do we do? Like, there are some pumps now that will allow you to do what we call the programmed intermittent boluses, or PIP. So the way it works, that you put the catheter and you program a very small rate of infusion, even like 1 or 2 ml per hour, to just keep the catheter going, right? And you program, let's say, 10 or 15 ml of a diluted local anesthetic, like every hour or every 2 hours. And essentially every 2 hours or something, it is just a big push through the catheter. So that way, like, the volume is going to spread, like, where it needs to be. So the answer to your question, yes, it is possible. But again, you have to think about the resources that you have. Like, a lot of times you may think it actually may be like easier to just go and just block these patients, like intermittently. The other thing that we have to think about, also elderly patient, at least like at least I find in my experience, like their pain experience is very different from like somebody who's young, robust, and 25, 30 years old. Really, once you get them like over that hump, really their pain threshold can be very different from these patients. So if you help them initially with a block, maybe just you want to do like a block again, a block in the ED, a block before surgery, and you continue them on very, very low dose of opioids and some multimodal anesthesia around the clock, a lot of times it is adequate. And this is just experience.
Thank you. Thank you.
Thank you. We have a question from the floor. I think this is Dr. Sharif. He's asking about the posterior pain. As we mentioned that the hip has anterior and posterior innervation. He's asking about the posterior compartment pain. And I think he's asking about the blocks that we can give for the posterior hip.
Do you want me to answer that, or somebody else want to take it? I'm happy to if...
Yeah, it's open discussion. All of you can reply. We can start with you, Dr. Nabil, and then Dr. Yasser if he has any.
So as Dr. Yasser alluded to, so the ping block, okay, this is good for either doing that block with local anesthetic, or with just doing maybe some sort of ablation, or for that type of patient, for that type of pain for the anterior capsule. And again, the density of the nociceptors and the mechanoceptor on the posterior capsule is very different from their density on the anterior capsule. However, very recently, I think it was in March of this year, the Chris Vermeulen from Europe, like he described a block technique for the posterior capsule of the hip. I think it's called the deep gluteal compartment, and this is essential in that kind of still like very novel. I would say the jury is out to see, when you combine that with the ping block, are you going to get really complete analgesia of the capsule or not? And the idea is you see the greater trochanter, you see the rim of the acetabulum at the back with the ultrasound. You put the local anesthetic around the rim of the acetabulum to get the nerve to the piriformis muscle and to get the superior gluteal nerve. And he suggested about like 20 cc. This is, again, the only thing I've seen on that was a cadaver demonstration and just a case report that was from this year. I don't know what the experience of everybody else.
Dr. Yasser, you have any comments? Dr. Wissam?
Yes, as Dr. Nabil said, it's a new block, need time to declare. But what we do in real life, if the surgeon make a block, if the surgeon going to surgery, just can give him 20 ml of 0.33 levocaine or lidocaine, and can make an infiltration for that area, because the innervation of the hip joint is not as simple as we think, and different between one and one, because the face is not the same, the anatomy is not the same. Not the same between people, even between the right side and the same person, and we see that in reality. Today, I don't found in axillary block, I don't found the musculocutaneous again. I search in everywhere, I don't found. Even I look for the fascia to be like an musculocutaneous, I don't found. So I injected 20 mil for the axillary, and it worked for the lateral cutaneous nerve of forearm, which came from the musculocutaneous. In the other side, you can find a very big nerve, like a star. You know, is it deficient only the arrow, what you see in the Boken's nerve. So this is what we can do in real practice, and it works most of the time. But this is working for many years. But I think is a new thing. It must be tried and to see it on high scale randomized control study. But it's a very good idea when you found something like this, because all things started like this.
I have also a comment regarding this, because the peripheral nerve blocks or interfacial plane blocks, it's a single component from the multimodal modalities to control the pain post-operatively. So simply, if we can find something like that, we can add very simple analgesics, non-steroidal, or acetaminophen, paracetamol, or whatever small doses of opioids can cover this. So multimodal analgesia, we can use a lot of modalities.
Also, just a little comment before Dr. Sahar takes over, this deep gluteal block, which is recently being described, will be working more for the chronic hip pain, I think, more than the acute pain, because as mentioned by Dr. Nabil, the anterior capsule is more nociceptive more than the posterior one. Floor is yours, Dr. Sahar.
I think also there is some explanation about, or some knowledge about the nerve to quadratus femoris. I don't know what is is it possible to do it this one, or just it's just explanation for the cause of the posterior pain, the posterior hip capsule pain. Dr. Nabil.
As I mentioned before, I think this is something
New?
Relatively new, and it involved the nerve through the quadratus femoris. I think only time can tell if this is going to be when you look at the ultrasound images. Okay, I think I may have something here to show you. When you look at the ultrasound images, I mean, it seems like something that is honestly very doable, right? And it doesn't seem, at least something that is going to be very very difficult, right? Here, I'm just going to bring it up here in a second, and I am gonna just make that bigger right here. Okay. Obviously, and I'm gonna share screen, right? So can you see this?
Yes.
So that's essentially this is not our work. This is a work from Chris Vermeulen, right? So this is essentially, this is your sciatic nerve right here, and this is going to be the nerve to the quadratus femoris that you are mentioning right here. And under ultrasound, it's gonna, this is the cadaver study, and I think under ultrasound it's gonna look something like this, right? I'll show you the ultrasound image, right? I think it was on the here too. Yeah. So again, this is the position, and this is, you see the greater trochanter, you see the femoral head and the femoral neck, and this is going to be the spread of the local anesthetic. It seems like not terribly complicated, but again, you have to remember that this is only description of a technique with some injection of some dye to see the spread, and the end, what they suggest that maybe just combining that with something that is going to get the anterior capsule, maybe that will be that will get the entire innervation of the capsule of the hip, both posterior and anterior. But also the idea, what Wissam was talking about, that when you do a block, even if it's not complete, right, the question is, I mean, does it need to be complete? Meaning, with the multimodal analgesics that we have, even if the efficacy of that block, let's say it's 60%, can our multimodal agents make up for that, like, for the remaining 40%? And the answer is mostly, in my mind, like, maybe yes, right? But again, like, if we want to do something that is like, more comprehensive, maybe in the future that we can do something that is going to involve both the anterior and the posterior capsule. But again, I'm going to ask you, like, what if, like, you have a fracture that's extracapsular fracture? What are you going to do, right? If you're specifically talking about a hip fracture. Yeah. So again, and it's almost everything is a balance. Okay, just you do something that is very sensory but doesn't involve motor, but also what if, like, the fracture and the surgical insult is beyond that? Do you have to go even, like, more proximal, and the taxes that you have to pay, that you have to get, like, some motor involvement, like, from the muscles? Because if you really want, like, dense analgesia for these patients, and I'm sure this is something that each one of you may have done, like, in the past. If that patient on their side and you did, like, a lumbar plexus, and you did a high sciatic, and that will be good, all right? That will be good, like, for the analgesia, right? And we did that in the past. But now, like, nobody likes, like, the entire leg to be numb because of the physical therapy and because of this and that, and this or deeper block, and it needs really a lot of coordination and a lot of skill set, especially if you're doing this deep blocks. So yeah.
Thank you.
Okay.
Thank you, Dr. Nabil.
Thank you.
We have a question from Dr. Sharif. I think he's asking, can we propose a denervation for the patient that can be operated? I think this question has been replied by Dr. Nabil already. That it's not only about the pain, it's about the surgery itself, and it's being important for the health of the patient. But to you, Dr. Wissam, can you please reply? Dr. Wissam?
Yeah, so maybe Wissam is not available. Do you want to move on to other questions?
Yes, Dr. Sahar?
From Dr. Muhammad, he said that can the isoparic bupivacaine used for local infiltration or the nerve block be used for spinal anesthesia? I think Dr.
same one.
Yasser.
The same one, yes. This is the isobaric.
Isoparic,
Who's
yes.
preparing in low socioeconomic countries, just putting an equal volume for if you wanted to prepare glucose 5%, 10%, it will be heavy. If you put it in saline, what's called the equal percent, it will be. This is just to prepare, but we use normal bupivacaine. This is an isobaric one.
Okay.
Thank you, Dr. Yasser. We have a question. He is asking about does the bang block causes motor block or not? The bang block.
Yeah. So the promise of the ping block, in theory, that it's not gonna result or affect, like, the motor block. I have seen a study, and honestly, I cannot remember, like, which one it is, that I think for there are a decent percentage of patients, like, the first 3 or 6 hours, there were affection of the motor response of that patient, right? And they were struggling to explain why, whether this is going to be spread, like, to the different branches, like, of the femoral nerve, possibly. But if you inject, like, high volume enough, and it spread to the femoral, it may get it. But in theory and principle, that when you inject at these distal branches that supply only the capsule, you shouldn't get much of it, or at least you're going to get a lot less than if you did something like a femoral nerve block or a fascial block.
Okay.
You know,
I
I have a
have
comment
question.
about. I have a
Okay.
comment, sorry about it. You know, when we started to use an official blend block, thinking all the time, just right, 35, 40 ml of diluted local anesthesia, and we did that for even was written for a big block, but we found most of this patient get a motor block and have a very low, what's called the quadriceps muscle. So I just read an article when I was preparing a fascial balloon block for one of the conference about when he started to use more than 20 ml of local anesthesia, it make a femoral extended to femoral block, because they found that the fascial balloon is communicated, and the dynamic contraction of the muscle in fascial balloon can make like injection for the car, and it worked. But I think it depends on volume, and this review article speak about many studies. If you inject a low volume, it will work. You know, Dr. Nabil, most of the studies when it started injecting a very high volume, we don't use this high volume now. We try to decrease it, to decrease the concentration, and it works. The same like this, and we don't just care about the toxicity like before. So when you get a paper, even high scale, and you try it, you found something, you must modulate your technique according to what you see. Thank you.
I have a question for you, Dr. Yasser. You said that in your presentation you have done bench block. You have done it as anesthetics, just for analgesia. You use it for analgesia. One of your papers or one of in your
this is not my paper. This is about one paper from China, one paper from Hamad, and many papers about it in some critical case. Usually use it as a solo technique, as one technique is on for analgesia, because just he work for the sensory branches for the joint more than the skin and stuff like this. But if you wanted to make it, you can make many blocks at the same time. So in hip fracture, in our group here, they make a femoral block of 10 mil, local anesthesia, bupivacaine 0.33 with lateral femoral cutaneous nerve 5 mil, and being a block about 15 mil. And I gave them TCI sedation was propofol. And it worked. It worked with me also in a case. I give that with dexamethasone on 0.5, because our patient here very sensitive for dexamethasone. So I give it 0.5, and he give infusion remifentanil about 3 hours, and it worked very good. But all the time, like a shoulder surgery, like any surgery, all the time we give the surgeon some local anesthesia and some syringe if the patient try to move, or I feel pain, he injected like any other block.
So did you consider the subcostal nerve, the ilioinguinal nerve also? Because sometimes they have a high incision for the hip.
This is according to the incision. What do you need from where is the incision? Anterior, lateral, posterior, according to incision. And even you can do that, but at the end, because there is an overlap all the time, and different innervation. In some cases, it's not one fit all. In some cases, you need this local anesthesia in the hand of the surgeon, and usually we look at very, very critical people, and most of the time succeed, But this is not like a high scale, just a case report, one case report, and all the research started like this, it started by drop.
Okay. Thank you.
I have a question for Dr. Nabil, if you please, Dr. Liz.
Yes.
Dr. Nabil, do you think is it a time to say goodbye for epidural analgesia?
That's a tough one. All right. So I honestly, but again, this is just a personal anecdote. You're talking specific about hip fracture, right?
Yeah.
I cannot remember, I've been here since, the year 2000, and I cannot remember, the last time I put an epidural in a patient with hip fracture. It's just because it's always these patients are gonna come either A, they are on anticoagulants, or B, they already taken heparin or taken Lovenox or whatever, and you really have to navigate that. And even if you are able to work with the surgeon for them to just either A, give subcutaneous heparin, or hold the enoxaparin to for a period of time, whether it's for 12 or 24 hours, for you to do the spinal, they will want to resume that post-op. And then it's going to be very difficult to navigate, like, maintaining an epidural catheter in these circumstances. The other thing also that there are, like, a lot of things. Yes, okay, you can do the epidural, like, lateral, right? But again, it's not going to be as easy, especially in elderly patient with a lot of arthritis and a lot of osteophytes in their back. It's just when you get, like, a spinal in, like, in these patients, sometimes you feel like, this is a big achievement, especially that to get them in position and just make it, like, adequate for them to do it. Sometimes it's not that easy. So
I agree. Yeah. Okay.
So when you ask about a general statement, like, is it time to say goodbye for the epidural? This is a very tough thing to do, right? But it can be done, but again, you have to really, really, really want to do it. All right.
Yeah, and for me, for my practice also, I haven't remember when I gave epidural for specifically for the hip fracture, but I would say that we should involve this technique in the analgesic technique, because a lot of anesthetists till now they are not mastering the nerve blocks or not mastering the use of ultrasound. So the conventional epidural still will be an option for them to provide analgesia for their patients. So I think we should keep it still in the scheme of post-operative analgesia provider.
As I agree with Dr. Nabil, I think because we have multiple options now. Before we don't have many options, but now we have an easy option, less easy to do, less problematic. Like even you need an what's called like what's called pathway. We need the patient to move fast. Sometimes unpredictable. Sometimes unpredictable for even to make a relaxation. So what I found, as Dr. Nabil said, I don't know, because it was a very common to make a cervical epidural for pain, even for pain. For pain, it started to disappear for neck, for example. I make transforaminal by ultrasound. So I need I see the nerve, I see what's the interrupt nerve to inject it around. It will become like an option. We have many options now, luxurious life now. And we have many easy things, like for example, electrospinal, like what's called or paravertebral, like an unilateral epidural. We see that, and as Dr. Nabil speak about the anticoagulant, very common now. Most of the people now can live for a long time and have a cardiac problem. Most of them take an anticoagulant. So I found, it was a fashion, but still, some people use it, and still in some selected cases, as I tell you, can put combined spinal epidural for long procedure, or can use another option for general anesthesia. Sometimes have a problem for general anesthesia or problem for epidural, but not used like before. I think everywhere.
Okay, Dr. Nabil, I'm so impressed of what you did to the emergency department in your university, and I just want your recommendations or your advice how we can adapt what you have done there in our societies here in the Middle East or in the Gulf area, Egypt, Sudan, these areas. So how can we utilize the emergency department physician to provide this analgesia instead of calling the anesthetist to do it? And we have some regional workshops from time to time, but what's your recommendations that we can overcome this problem and give them some privilege to do that in the ED?
Yeah. So this is a great question. And this, I will have to be honest with you, this was not something easy, right, that we did. Because as an anesthesiologist, like everybody here, we like what we do, right? And it's not easy to essentially defer or teach somebody else, to do, what you do. But emergency medicine, have come, a long way. And the nerve block that we talk about, if you look at the YouTube channels that they have in the emergency medicine, they talk a lot about ultrasound and ultrasound blocks, and they do ultrasound. They probably use ultrasound a lot more than we do as anesthesiologists. And there are, at least in the States here, there are fellowships in ultrasound now in the emergency department. I'm not talking about anesthesia. So first, I think just you have to reach out to them, and communication is going to be key. And you have to pick a champion, like, somebody that you partner with. Like, let's say that one of your friends and somebody who really believe in this, and somebody would champion that on their side, on the emergency department side. And most of the time, to be honest, you're going to find people in the emergency department, at least our experience, they're going to be one of two groups. A group that is relatively early career faculty, and they are very open to learn new techniques, very open to learn ultrasound. And the group who are probably a little bit more senior, and maybe a little bit more resistant to adapting new technique or learning something. And their claim is gonna be, I am gonna do something. This is gonna be opening me up to liability. I'm doing something I may or may not be comfortable with. So one of the things I put up in my presentation, that actually you can pull up your iPhone, and we just did a laminated card for them. We put it on the ultrasound machine. If they open the camera on their iPhone and they scan the QR code, literally each video was like 2 minutes. It's almost like a crash course before they go to that patient room, other than the workshop and everything that they do. And for those who are not even comfortable with the ultrasound, honestly, we emphasize that you can do this block even without using ultrasound. When you're talking about countries in the Middle East, when you talk about Sudan, Ethiopia, anywhere, you're gonna have needles, and you're gonna have local anesthetic, right? And you're gonna have patient with hip fracture who's gonna be suffering from pain. So if we make that as an initiative, and I look at something like that Egyptian society, this is a young society, and it has so many connections. And let alone forget about, if we're talking about the Egyptian society, maybe, and now I've been removed from the practice in Egypt for a while, but don't think about the big cities, don't think about the university centers, don't think about Ain Shams, don't think about Manufaya or Iskandaraya. Think about really just the the areas that are they are very low resources. But even in the lowest resource possible, you're still going to have needles, and you're still going to have local. And if you train people on the very basic techniques, when they just infiltrate the skin, they go through skin, and they're going to have markers. Okay, this is the symphysis pubis, this is ASIS. You're going to draw that line, and it's almost back to the future. You're going to take a trip back in in the technique. Yes, I'm the biggest advocate for ultrasound and the biggest advocate for the new techniques. But if you kept telling people that they don't have ultrasound, you're not doing anybody any favor, right? But if you take it to the basics, and really you just try to give them something within their hands, and something that they can do tomorrow, right? That, I think, this is going to be probably the best service that you can offer to them and patients. Because let's say, even if you argue, say, well, this works only in 75% of the patient, the landmark technique, and it has a high failure rate. But guess what? 75% is way better than offering 0 blocks.
Yes.
So, can I have a comment, please?
Sure.
Thank you.
We are waiting for your comments, Dr. Sattar, anytime.
Thank you. Just one comment. I think that the intelligent ultrasound can promote this function for the emergency physician. They can help them how to identify the muscle, the nerve, and they can do great by using this one. The second comment, I'm sorry, as they are now mostly professional in airway management in emergency department, so we can expand our knowledge and experience in pain management in emergency department for the multiple trauma patient. As we have managed pain early, we will have less less stress for the patient, less complication, less comorbidity, etc. Thank you.
Thank you.
I have a comment, Yasser, because you speak about a very interesting thing. Because today I gave
13 calls from the emergency. 13 calls, you imagine, in 12 hours.
Too much.
You know, the problem here, he have a privilege or not, have a training or not. The people in Gulf area just use a conservative medicine. He need to make a block, but he call you to be there because of responsibility. He can put at you, but he call you and you can say no because you have a responsibility if anything happen. You call you to treat the patient from pain and even to make a block in emergency. And he can do it because they train with our workshop and they can make the basic block. So he can make it if he don't feel any responsibility. But the problem, you know, usually he need a backup because it's conservative medicine. And I think it to solve it is very difficult because we try to make only a workshop for these people in ICU and workshop for regional anesthesia and people in emergency. And up till now so succeed with the original old man. I don't know what is the name. He left already. And was about to do that. But at the end, we discovered it's a conservative medicine. I don't know in America or like in Gulf area. Everyone is scared to do anything. The most important thing, the documentation and to protect himself. Even he can call consultant specialist to be with him during tube. And today I sent them 2 of our specialists and one a resident because last one. And he said that tube was very easy, but was scared and he need another person to be in time. And they can't see no all the time, you know. So I don't think it can be solved easily, yes, especially in our, you know, Gulf area.
We will try. We will try.
Yeah.
We'll try for
Please
6 years. And you get frustrated.
Yeah, no, but I think also like what you can do as as leaders. So, for example, like the hospital that you're talking about, I understand that both you and Yasser, you work in the same hospital. So, as leader in this department, you can say, okay, we're going to put a program not only for initial training but also for maintenance of competency. So, let's say that each one from these physicians every year they are gonna have to provide documentation that they essentially did 10 blocks supervised under a supervision of an anesthesiologist, and they have to provide like a documentation of 5 or 10 blocks like they did on their own, right? And let's say that we're gonna have an annual workshop like that for these physicians every year, and they're gonna come back. So this is almost maintenance of certification, and just you provide documentation how to really maintain competency. So competency and certification, providing privilege, maybe this is something that you can essentially just give them the guidance. What is the minimum requirement to provide those in a safe way? Safe way.
I agree. Sahar? Sorry, Sahar?
Yes. I think there is nothing left for the questions by the audience.
I think Dr. Muhammad Gouda asked about spinal something, you know, he writes,
Yes.
he either to say a
Yes.
comment or he
Yes.
does say a comment.
Where is
Yes,
it?
Dr.
Thank you
Gouda.
all for your very informative presentations and lectures. I think it's too late, but I just want to comment about continuous spinal. I think you mentioned that no difference in the literature or studies between GA and spinal, including continuous spinal. But, I think it should be in a separate study regarding the low volume. We are talking about very fragile and with high score frailty. These patients cannot tolerate even brief periods of hypotension. And this hypotension will lead to comorbidities, ICU admission, morbidity and mortality, and delirium. So I think with the very low volume, my last patient, I gave him only 1.4, even 2 hours. And regarding the complications of the continuous spinal mentioned or explained in the literature, I think that's because they use the micro catheter, the 29 millimeter. But now we can use the two with the traditional or the conventional epidural catheter, and this will lead to much less complications regarding the hypotension, delirium, So I think we can use it in these fragile patients, 90 years, 85 years, regarding all these complications.
I don't understand you. You agree about spinal. I'm just showing a study,
I think
and you know you need the data all the time. I show the study, but I don't use a continuous spinal. But I found as a teacher, many people use it, and there is special catheter, not in epidural, special catheter, multi-orifice, to don't make a what's called concentrated local anesthesia, and you don't inject lidocaine before. But you know that the most important thing about spinal, epidural, general anesthesia, don't let the patient to go for hypotension. And you know, in my hospital here, and in my hospital, just we started infusion phenylephrine from the beginning, proactive, and you can hold it. But all the time we use it because even in a woman hospital here for a normal patient, I think any technique can be valid and work. But the problem, as you said, don't make an hypotension and must treat proactively. So we can, you know, some people now here for any spinal, they prepare phenylephrine from the beginning, because hypotension, as you said, is very dangerous, especially if it's stay for a long time, you know. And the dose is different from one to one, place to place. And if you have a back problem, a spinal canal cirrhosis, if the patient is very long like me or big like me, he can't, you know, can't tolerate a higher dose in another comorbidity. But all the time, remember that all the age, even it is as a one who don't have any disease, is still have a fragile patient and have defecting reserve for the organ.
That's why I said I think they should standardize the inclusion or exclusion criteria regarding the continuous spinal in comparison with the GA or the conventional spinal anesthesia.
You are right. Even for example, I put a slide first. Why this is a difference between study and study? Because the secondary outcome and primary outcome is not the same. Some studies speak about which is better in delirium, another one which is better in postoperative complication, another one which is better. So collectively, when you make a meta-analysis or you collect many studies, and if you have a bias in the studies, it can be bias even meta-analysis. But as you said, you know, we don't have many things to ask, and we need more study to standardize everything, and this won't happen. And if you can do it, it will be well appreciated, just to make another study to make a standardization. Even you know that when we speak about spinal after 24 hours, we don't know what happens this 24 hours. No one said. And when you speak about spinal and delirium, they don't write in the methodology how much of this patient take a sedation. Even some patient take a heavy sedation, like a general anesthesia, and they account that the patient is spinal and have failed delirium. So there is many bias in studies, as I told you at the beginning, and we need to standardize. I said, but the standardization in this case, it will be very difficult because the patient have different comorbidity. But still, you know, if you're collecting the advantage of disadvantages like spinal and general anesthesia, you found a very what's called minimal difference between the outcome. Globally is outcome, but maybe different from area to area, as you said. Thank you.
I think Dr. Gouda, as Dr. Nabil said in the last slides for the take-home messages, do whatever you are familiar with. So according to the situations, according to your patients, according to the facilities around you, you choose, you have your plan and what is called the anesthesia tailored plan for each patient. This one, the continuous spinal is suitable. The other one is not. Whatever you are familiar with, according to the circumstances and situations, do it.
Yes.
Totally agree. Even in any special, in any anesthetic technique with any type of any operation, and
Yes.
all the drug you are familiar with special type of induction of GA, so proceed for it. You know the drug pharmacology and dynamics for these patients. Yes, it's okay. Use it.
All right. You know, this is a very interesting thing about this. In UK, we went there a nice make a standard, like a protocol for hip fracture from the beginning, until the patient discharge. They found out, they make audits, found 54% of the physician not following this guidelines. Because it can't be a solid thing like this.
One more thing also about the analgesia in the ICU. as Dr. Nabil mentioned, talked about the emergency department. Nowadays, in the recent editions of ICU books, they are talking about the nerve blocks in the ICU to treat delirium and pain and to hasten the discharge from the ICU.
Now we have two competitors, the emergency medicine physician and the ICU physician, because because anesthesiologists have more practical practical things and go there and there. So they want to displace us from the ICU, displace us from the emergency room, and we will be confined to the OR
yeah,
only.
I don't think it is a matter of displacement or something like that. Actually, they are unloading some of our responsibilities
Yes.
from us, and they are
really,
helping us to do.
yes, I really admire one of our colleague in emergency department in Manufia University when he said to me that Dr. Safa, we have limited practical or hand maneuvers to do. So we expand our experiences by studying ultrasound. They can do transcranial Dopplers, they can do POCUS, etc. So they want to expand their daily practical experience to have more work. Especially
The good news, Dr. Muhammad, about what you said, there is an international conference. I was making an workshop for being and regional with Yasser Tayyib and our team, and people from emergency and from ICU suggested for the next conference it will be one for general anesthesia and one workshop for the procedure done in ICU and another one, and we will be prepared for it for the people came for emergency. And it's a very good idea. We discussed it before, and inshallah, when it settle down and become a program, I will tell you inshallah.
inshallah.
inshallah. شكرا دكتور جودة، شكرا.
ربنا يخليك يا فندم، تسلمي، شكرا.
Any question from the floor?
I think there is nothing, no questions in the chat.
So now this is a hard time for me. This will be the end. Really, the very, very happy end. And very, very happy end for 2023 scientific session. And I would like to expand one word for one of my prestigious gathering today. I will start by Nabil Kasabani. Thank you, Dr. Nabil. Really, I haven't any suitable words or letters to thank you for your humanity and humility and your kind response to address this session today. I know that you have time difference between USA and Egypt, but you are in a very kind and supportive way, support the Egyptian Society of Anesthesiology and Acute Care by this amazing and outstanding session. Thank you for time. And let me speak in Arabic for you. جزاك الله عنا كل خير وأخلفه عليك بركة في المال والأهل والولد وحفظك الله وبارك فيك. وأنا الحقيقة ما خدتش وقت وأنا بقول لك ممكن تقول لنا محاضرة، وكانت الإجابة على طول طبعا، وأنت مستنية إيه؟ فإذا أنت نبيل اسما ومعنى. شكرا يا دكتور نبيل.
ربنا يخليك يا دكتور صفاء، وانا I'm happy to help in any way at any time. يعني
Thank
this
you.
is not يعني any time.
Thank you.
وكل سنة وانتم
Thank you.
طيبين
Thank you, Dr. Nabil.
ممكن اقول كلمه يا دكتوره صفاء؟
Dr. Wissam.
أنا هقول وبعدين أنت قول.
طب ماشي، كلمه صغيره.
يعني all the appreciation and the greetings for Professor Dr. Sahar Kamal. Dr. Sahar Kamal, I call her on my phone agenda as Sahar Hanem. Really, she is behaved like the princess always, and she is so kind and so beautiful one. Thank you for time today, Dr. Sahar, and please, I beg to you to be continuously supporting ISAC program, online program, for the expansion of network of knowledge and the friendship all over Egypt and outside Egypt also. Thank you, Dr. Sahar, for your time and effort today, and I hope many, many times to be with me. Thank you.
Inshallah. Thank you very much. Thank you very much.
Thank you. Of course, شهادتي of course I am biased with Yasser Tobl, but he is the head of faculty of pain and regional anesthesia in Egyptian Society of Anesthesiology and Acute Care. And I don't, I will not mention his upper hand and his support for the society from the first minute or minute zero. Also by his money, of course. So I have no, I am biased. I am biased, and I have disclosure for you what I can do. As regard my great son, Yasser al-Tayyib, he everyone has like we said in Arabic له حظ من أو من اسمه. وفعلا أنت كلك يسر وكلك طيبة، وفي نفس الوقت علم نافع إن شاء الله، وحضور طاغي، ومناقشة واعية، ويعني طول الوقت بتقدم خدماتك للإيجيبشن سوسايتي اوف انستيسيولوجي اند اكيوت كير. جزاك الله عني خيرا الابن العظيم ياسر الطيب. شكرا جزيلا.
اللهم امين.
اللهم امين. طبعا بقى يعني انا ما اختم فاختم ختامه مسك، وانا بحب المسك جدا جدا بصراحه يعني، وحسن الختام، وان شاء الله ربنا يكرمه، وان شاء الله كل التقدير والتحيه للمخلص المعطاء، رمز وايقونه اسم التخدير جامعه المنوفيه، دكتور وسام سلطان، لعلمه وأدبه الجم، وإن هو الجود ايمج بتاع الاسم عندنا، وفي نفس الوقت بتاع الجمعية طبعا. وهو أنا عارفة إن هو ممكن يعمل انقلاب وينقلب عليا، فده عادي برضو، أنا موافقة، ويبقى هو الرئيس الشرعي، أنا موافقة. I'm totally agree.
never happen.
أنا عايزة أقول لكم بجد بجد يعني الكام دقيقة دول صعبين عليا جدا، وانا حاسبكم، لان انا كنت حاسة ان احنا قاعدين في مكان واحد بجد، وان ربنا يكرمكم، وشكرا جزيلا يعني، شكرا جزيلا. دكتور ياسر لو حضرتك حابب.
انا بس اقول كلمه كلمه بسيطه. طبعا صوتي رايح من الكلام مع الجراحين النهارده والخناقات بتاعت الصبح
وال 13 كول.
ف ف يعني انا بشكرك جدا دكتوره صفاء، لان جمعتينا بواحد من الايكونز اللي انا بحبهم من غير ما اعرفهم، دكتور نبيل، واللي انا يعني بشوف في الريسيرش بتاعه وكتبه. استفدنا جدا منه، واستفدنا جدا من الحضور ومن الاسئله. انا نفسي استفدت جدا يعني، على الرغم ان انا كنت اتمنى ابقى فايق اكتر من كده. ولكن بشكر الدكتور نبيل، انا عارف وقته ثمين جدا، وبشكركم جميعا، وبشكر كل الحضور. وان شاء الله نلتقي في السنه الجديده باذن الله قريبا في اكتيفيتي ثانيه ان شاء الله. وجزاكم الله خيرا على الحضور.
ان شاء الله ان شاء الله. شكرا جزيلا لكم جميعا، شكرا جزيلا.
ألف
شكرا.
سلامة، كل سنة وأنتم
شكرا.
طيبين.
طيبين.
كل سنة
مع السلامة. مع السلامة. مع السلامة.
السلام عليكم.